Selamat datang di Mercy Pharma, Planci Kembar, Sukabumi. Pabrik yang dibangun di atas lahan 14 hektar terdiri dari 8 bangunan gedung produksi dengan fasilitas ruang kantor dan R&D. Serta dilengkapi dengan laboratorium kimia dan mikrobiologi yang modern, bertujuan untuk memenuhi kapasitas besar produksi obat-obatan. Untuk pengembangan produk, peningkatan kualitas, dan pemastian mutu produk yang dijalankan oleh SDM profesional dan berintegritas tinggi yang menempatkan mutu produk sebagai pedoman utama dalam karyanya. Sejak berdiri pada tahun 1997, dimulainya pembangunan hingga 1999 mulai berproduksi, didukung dengan fasilitas produksi dengan teknologi terkini yang memenuhi standar cara pembuatan obat yang baik. Dalam wujud visinya menjadikan Mercy sebagai industri farmasi unggulan di dalam negeri maupun di luar negeri yang berstandar internasional. Tujuan kami adalah untuk membuat produk-produk berkualitas tinggi yang berkapasitas besar, efisien, dengan biaya kompetitif di pasar lokal dan ekspor. Kami bangga memiliki peralatan yang baru dan modern untuk melengkapi fasilitas canggih kami. Semua peralatan diuji dan divalidasi sebelum setiap produk diproduksi. Prasarana untuk kelancaran produksi sehari-hari mencakup kompres air untuk menggerakkan mesin produksi, purified water system, sistem pengolahan air murni untuk bahan baku obat dari penyulingan hingga distribusi ke semua gedung. Boiler room, proses pembuatan uap panas untuk proses produksi dan proses pengolahan water for injection. Gedung unit-unit produksi sebagai gedung pengolahan obat-obatan dengan bahan baku kimia. Memproduksi beberapa jenis produk unggulan antara lain tablet salut, kaplet, kapsul, serbuk oral, injeksi, infus, maupun cairan oral dan krim obat luar. Untuk dapat mempertahankan kualitas hingga lini akhir, proses produksi Mercy menyimpan produknya dalam gudang dengan kapasitas lebih dari 3.500 palet, terbagi atas beberapa kondisi suhu dan kelembaban tata ruang. Guna menjalankan misi Mercy untuk menyediakan dan memasarkan obat yang bermutu, tersebar merata, tersedia cukup, dan terjangkau masyarakat seluas-luasnya. Untuk meningkatkan derajat kesehatan masyarakat Indonesia dan internasional, dengan kantor perwakilan Mercy siap melayani pelanggan di seluruh Indonesia. Pada masa yang akan datang, diharapkan Mercy dapat memelihara dan meningkatkan eksistensi perusahaan untuk membangun Indonesia dalam dunia kesehatan. Karena kesehatan Anda adalah prioritas kami. Kami yakin dengan kualitas obat yang baik akan meningkatkan kualitas hidup.
Assalamualaikum warahmatullahi wabarakatuh. Greetings to all of us. Om Swastiastu, Namo Buddhaya. I am Veronica as host in this virtual seminar at this afternoon. Welcome to join the virtual seminar of Indonesian Psychiatric Association Jakarta Branch in collaboration with Abipraya Foundation and PT Mercy Pharma, which is ED certified. The topic of virtual seminar this time is Substance Use Disorder, Mental Health and COVID-19 Pandemic, Changes and Challenges with speakers Darnardi Sosro Sumiharjo, Medical Doctor, Consultant Psychiatrist, Chairman of Section on Addiction Indonesian Psychiatry Association, Diah Setia Utami, Medical Doctor Psychiatrist, Dr. Mars, President of Indonesian Psychiatric Association, Siva Kumar Turai Rajasingam, MBBS MedSych, Consultant Psychiatrist and Associate Professor, Jeffrey Che School of Medicine and Health Sciences, Monash University, Malaysia. Miriam Pichu, PSD RPC, RPM, RGC, ICAP3, Consulting Clinical Psychologist and Director of Psychological Services, New Day Recovery Center, Philippines. And also moderator this afternoon, Zulfia Sharif, Medical Doctor Psychiatrist, Board Member, Indonesian Psychiatric Association. All right, Dr. and colleagues, before we start the virtual seminar this afternoon, we will listen first the speech from Abipraya Foundation, which is presented by Dr. Anda Riza Sarasvita, MSc, PhD. Please, Mrs. Riza, time is yours. Hello, Mrs. Riza, how are you?
Yes, I'm okay. Thank you, Mr. Shiro. Good afternoon and greetings to all of us, doctors, psychiatrists, psychologists, students, and all colleagues. Thank you for joining this webinar. I do hope that you are all in a good condition and health and not overwhelmed with various webinars during pandemic. This webinar is held by the Abipraya Foundation with support of Mercy Pharma Company. Let me briefly introduce what about the Abipraya Foundation, which was built in 2015 by scientists, practitioners, and researchers in the area of substance use disorder, mental health, and HIV/AIDS, such as Professor Samsurizal Jauzi, Professor Zubairi Zurban, both of them are from the University of Indonesia, Professor Suharko Kasram from the Faculty of Medicine, University of Trisakti, Dr. Diah Setia Utami, psychiatrist, Dr. Vivi Syarif, psychiatrist, Dr. Sandi Noveria, Master of Health, and Hepa Susami, Master of Science in Public Health. And the missions of our foundation are as follows: to provide evidence-based information, education, training, and consultations related to SUD, mental health, and character building, as well as parenting techniques through various modes, face-to-face or virtual training, and also through our website. So this webinar for us is one of our milestone steps. We are very grateful to all of the participants who are joining the seminar, to all of the speakers, particularly my two best friends, Dr. Siva Kumar Turai Rajasingam, and also Dr. Miriam Q. Thank you for spending your weekend for all of us. I think that's all the brief information about the Abipraya Foundation, and I would like to pass the microphone back to the moderator. So I hope that all of you can enjoy the seminar and get maximum benefit of it. Happy seminar. Thank you.
Thank you. Thank you, Mrs. Riza, for your opening speech. Now let us listen together with the opening remarks from Jakarta branch of Indonesian Psychiatric Association. It will be representative of Dr. Eva Suryani, psychiatrist, as well as opening a virtual seminar event this afternoon. Welcome, Dr. Eva Suryani.
Thank you, Ms. Veronica. Good afternoon. I represent the General Chairman of Association of Indonesian Psychiatric Jakarta Chapter, Dr. Nova Rianti Yusuf. Welcome to this virtual seminar titled Substance Use Disorder, Mental Health, and COVID-19 Pandemic, Changes and Challenges. First of all, I want to thank all the speakers and also PT Mercy Pharma to support this event, and all participants who will spare time to join this virtual seminar. In response to the COVID-19 pandemic, many countries introduced response measures like self-isolation, quarantine, suspension of institution in order to prevent further spread and mitigate its effect. Undoubtedly, this situation also affect alcohol and substance uses. Some people may find themselves drinking or using substance more to cope with anxiety, negativity, stress, and our changing environment. Research of 3,219 respondents aged 18 years and over across Australia reported that alcohol consumption has doubled this year. Other than that, the United Nations Office on Drug and Crime Regional Office for Central Asia also reported the number of seizures of synthetic drugs in Kazakhstan has tripled compared to the same figure of 2019. Continuing development of medical education during the COVID-19 pandemic, PDSKJI has often held events and recently collaborated with Alomedica as well. The General Chairman of PDSKJI Jaya recently received NURI Award for holding the most mental health online speaker during the last 3 months of lockdown period. Remembering the importance of mental health in various settings, in various countries, including Indonesia, PDSKJI Jaya will continue to create online event. Let's have a moment of silence to pray for all the health workers. This is to pay respect to those who have died and who are still struggling to help COVID-19 patients to be given safely. Okay, thank you. In the end, I would like to say again, thank you. Hope you will enjoy this seminar and also get the benefit of this virtual seminar. Thank you, Ms. Veronica. I give it to you again.
Thank you, Dr. Eva Suryani, psychiatrist, for your opening the virtual seminar this afternoon in the Q&A columns of this provider. Well, allow me to introduce the moderator to today's virtual seminar. She is Zulfia Syarif, medical doctor, psychiatrist. She currently a board member of the Indonesian Psychiatric Association. Dr. Zulfia Syarif was invited to moderate the virtual seminar today. Welcome, Dr. Vivi.
Thank you,
Hello,
Carol.
Dr. Vivi. How are you today?
I'm great.
Yeah.
How are you?
Finally, we meet again after our last virtual seminar.
Yes. It's been great that we can reconnect in another virtual meeting.
Thank you. Please, Dr. Vivi, to guide us in this our virtual seminar at the afternoon. Time is yours.
Thank you so much. Thank you, Veronica, as our host for this afternoon's webinar. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. I'm very glad that I'm very glad that we can meet virtually in this afternoon for the webinar, Substance Use Disorder, Mental Health and COVID-19 Pandemic Changes and Challenges. And we'd like to thank the Abipraya Foundation, PDSKJI Jaya, and also PT Mercy Pharma for conducting this webinar for all of us today. And today we are going to learn about substance use disorder and also mental health during this pandemic period. From our experts, we have Dr. Danardi as our keynote speaker for today. And then we also have Dr. Diah Setia Utami from Indonesia. We have Dr. Siva Kumar Turai Rajasingam from Malaysia, and also Dr. Miriam Q from Philippines. I would like to say hi to our speakers first. Good afternoon, selamat sore, Dr. Danardi.
Halo.
Selamat sore.
Good afternoon.
Sore, Dr. Dia.
Semuanya.
Dr. Siva, Dr. Miriam, how are you?
Hi, hello.
Thank you for joining us this weekend, this afternoon.
My privilege.
Well, we are going to proceed with our first speech for this webinar. We are going to hear a keynote speech from Dr. Danardi Sosrosumiharjo, SPKJ Consultant. Dr. Danardi is a consultant of addiction psychiatry. And currently, Dr. Danardi is the chairman of Addiction Psychiatry Section of the Indonesian Psychiatric Association. Dr. Danardi is also the chair of Honorary and Professional Ethics Board of Indonesian Psychiatric Association and a member of expert groups at National Narcotics Board. So for today's webinar, Dr. Danardi will give a keynote speech of the topic Ethico-Medical Legal in Substance Use Disorder Management. Before I present Dr. Danardi for the talk, I would like to remind the participants that this webinar will be delivered in English, but some parts of this webinar will be using Bahasa Indonesia for further understanding and better understanding for Indonesian participants. But we are going to continue the discussion in English. Dr. Danardi, the time is yours.
Thank you, Dr. Vivi. Good afternoon, all of you speakers and participants. Thank you for inviting me in this seminar. I apologize. Let me speak in Bahasa Indonesia. Saya diberi judul Ethico-Medical Legal in Substance Use Disorder Management. Dan untuk kali ini, dengan waktu 15 menit, saya ingin lebih fokus pada bagaimana kita memberikan obat-obatan, terutama psikotropik, bisa sesuai dengan etik, medik, dan legal. Oh, slide ya. Dengan berbicara 3 hal, etik, medik, legal, itu kita berarti melihat ada 3 irisan. Irisan etik, irisan disiplin, dan irisan law. Kalau berbicara etik, itu kita bermula dari sumpah dokter, bahwa sumpah dokter itu bermula bahwa cita-cita luhur dan martabat profesi ini harus kita jaga terus. Dan itu kemudian kita wujudkan di dalam Kode Etik Indonesia atau buku Kode Etik Kedokteran Indonesia. Dan kita melakukan suatu tindakan di dalam suatu pelayanan kedokteran itu ada kaidah-kaidahnya, ada kompetensi dalam bidang ilmunya. Maka itu akan dituangkan di dalam kompetensi dan disiplin keilmuannya. Dan ketika kita melakukan tugas pelayanan, kita melakukan pertolongan kepada pasien, itu ada undang-undang yang mengaturnya. Ada regulasi dari Kementerian Kesehatan. Itu semuanya harus kita ikuti. Slide. Kita mulai dari sumpah dokter, bahwa saya akan menjalankan tugas dengan cara yang terhormat, bersusila dengan martabat pekerjaan saya sebagai dokter. Artinya di sini bahwa kita semua yang sudah memilih profesi luhur ini, kita harus tetap menjaga diri kita agar kita menjalankan tugas ini dengan moral, dengan kesusilaan yang tinggi, dan tetap menjaga martabat yang terus-menerus kita jalankan. Tentu tidak mungkin bahwa sesuatu yang abstrak ini tidak kita tuliskan, tidak kita bakukan. Maka muncullah ada kode etik, ada buku Kodeki, Medical Ethics. Dan kemudian juga dari Ikatan Dokter Indonesia ataupun juga dari Perhimpunan Dokter Spesialis Kedokteran Indonesia itu menyusun kompetensi. Tentunya ini dari Majelis Kolegium bisa merinci bahwa level-levelnya seperti apa apabila kita melakukan tindakan di bidang kedokteran, khususnya kedokteran jiwa. Slide berikutnya. Di dalam buku Kodeki atau Indonesian Code of Medical Ethics ini, ada 4 hal. Yang satu berbicara tentang kewajiban umum, tentang kewajiban dokter terhadap pasien. Barangkali nanti fokus untuk hari ini adalah kewajiban dokter terhadap pasien. Kemudian ada kewajiban dokter terhadap teman sejawat. Kemudian kewajiban dokter terhadap diri sendiri. Ini juga akan sedikit masuk nanti bahwa dokter pun harus bertanggung jawab untuk dirinya sendiri. Selanjutnya, buku Kodeki itu ada 21 pasal. Saya hanya mencuplik beberapa. Kalau pasal 1 tentang sumpah dokter itu sendiri, bahwa kita menjaga martabat yang luhur ini. Kemudian kita bisa memberikan pelayanan yang baik di dalam pelayanan kesehatan. Jadi pengambilan keputusan itu harus secara profesional. Kita sebagai dokter dididik untuk independen, sesuai dengan keilmuan kita, dan terus mempertahankan perilaku profesional. Kemudian pasal 8, apa itu profesional? Yaitu memberikan pelayanan sesuai dengan kompetensi kita. Kita diberikan suatu kebebasan, baik itu secara teknis, ada modalitas terapi yang banyak, tetapi tetap menjaga moral seutuhnya. Kita menghormati manusia, kita menghormati pasien, kita melakukan pelayanan ini dengan rasa kasih sayang sesuai dengan martabat manusia. Pasal yang ke-14, kalau seandainya bahwa kompetensi saya tidak memadai, atau karena kita merasa bahwa pasien ini cukup sulit untuk dihadapi oleh diri saya, maka saya harus mengkonsultasikan, saya harus mereferalkan, saya harus merujuk kepada dokter lain yang mempunyai keahlian untuk penyakitnya. Kemudian pasal 17, bahwa kita wajib memberikan pertolongan darurat. Meskipun barangkali kompetensinya itu di atas saya, tetapi untuk emergensi saya bisa menolong sebentar dan kemudian harus saya refer juga atau saya rujuk bisa ke rumah sakit atau ke dokter lain yang lebih mampu, lebih bisa menolong yang lebih baik. Pasal 19, bahwa saya dengan teman sejawat lain itu tidak boleh sembarangan mengambil alih, bahwa tanpa sepengetahuan dari sejawat saya harus dengan tata cara yang baik dan dengan persetujuan bahwa pasien itu ada pengambil alihan. Slide berikutnya. Bagaimana untuk bisa menjadi seorang profesional, ternyata itu ada beberapa hal yang bisa kita lihat. Bahwa nomor 1, regulasi. Bahwa kita bekerja itu harus sesuai dengan koridor aturan yang ada. Dan kita mengacu juga bahwa ada disiplin keilmuan. Disiplin keilmuan itu yang harus saya patuhi. Kemudian kedua, bahwa ketika kita memberikan pelayanan, itu kita bekerja di suatu fasyankes, kita bekerja di rumah sakit. Di rumah sakit itu pun ada tipe-tipenya. Di rumah sakit itu juga ada kemampuan. Ada PPK 1, PPK 2, PP 3. Itu juga yang membatasi ruang gerak kita. Kemudian yang ketiga, bahwa tugas yang diberikan kepada kita itu semuanya harus ada koridornya. Baik itu secara etik, baik secara medik, baik secara hukum, dan juga secara legal. Itu yang harus kita menjadi pegangan kita ketika kita memberikan pelayanan kepada pasien-pasien kita. Slide berikutnya. Kita sekarang merinci satu persatu bahwa apa yang bisa kita lakukan untuk sesuai dengan regulasi yang ada. Kita tahu bahwa kita harus punya STR. STR itu harus diperbarui setiap 5 tahun. Itu di dalam pasal Kodeki bahwa seorang dokter itu harus selalu mengupdate. Tidak mungkin bahwa teknik kedokteran yang sudah 50 tahun, 30 tahun, 40 tahun tetap kita gunakan pada saat ini tanpa kita melakukan suatu update. Sangat mungkin bahwa teori yang lama itu masih bisa kita lakukan ketika pasien itu memang pas untuk itu. Tetapi bahwa banyak juga pasien yang harus dengan teknik-teknik baru. Kemudian SIP, surat izin praktek, kita dibatasi 3 tempat. Mengapa dibatasi 3 tempat? Ini kaitannya dengan kewajiban dokter untuk dirinya sendiri. Tidak mungkin dokter itu 24 jam praktek terus-menerus. Dokter itu juga harus menjaga kesehatan, dokter itu juga harus merawat dirinya sendiri dengan baik. Kemudian regulasi yang lain adalah yang dikeluarkan oleh perhimpunan bahwa itu diberikan sertifikat kompetensi. Ada PDSKJI yang ada psikiater yang konsultan, ada psikiater yang belum konsultan. Kemudian kita bekerja itu juga ada regulasi yang lain yang barangkali ini kaitannya dengan hukum bahwa ada undang-undang praktek kedokteran, juga ada Permenkes, bagaimana regulasi mengatur kita ini harus praktek seperti apa. Slide selanjutnya. Kemudian rumah sakit. Rumah sakit itu juga diatur bagaimana fasilitasnya, bagaimana kemampuan untuk memberikan suatu pelayanan. Rumah sakit mempunyai standar pelayanan kesehatan, mempunyai SOP, mempunyai tugas-tugas, ada komite medik, ada komite kredensial, di mana bahwa membina, mengawasi, dengan mengevaluasi mutu pelayanannya seperti apa. Tentu diharapkannya mutu itu dijaga atau mungkin juga kemudian ditingkatkan. Dan jangan lupa bahwa rumah sakit itu juga diberi hak untuk menseleksi, memilih dokter yang baik, memilih dokter yang pas untuk kompetensi atau standar dari pelayanan yang ada di rumah sakit tersebut. Berikutnya, slide. Kemudian bagaimana kita bisa menjadi profesional? Tentu kita kembali lagi tadi bahwa ada Kodeki. Kita di Perhimpunan Kedokteran Spesial Kedokteran Jiwa Indonesia itu sudah membuat 10 standar pedoman etiko-legal. Ini juga bisa menjadikan panutan, bisa menjadi pedoman kita apabila kita ketemu dengan kasus-kasus yang memang diperlukan sesuai dengan standar etiko-legal itu. Dan suatu sikap standar dunia kedokteran ini tentu mengacu ada beneficent, non-maleficent, di mana pada dasarnya bahwa ketika kita memberikan pelayanan bukanlah untuk memperburuk kondisi pasien kita, justru bahwa kita harus mencegah terjadi efek buruk. Kita tidak mungkin meracuni pasien, tidak mungkin kita memberikan sesuatu yang berlebihan kepada pasien tidak sesuai dengan keilmuan kita. Justice, kita harus adil, otonom, kita bisa berdiri sendiri, kita tidak terpengaruhi apakah saya berhak, tidak berhak. Itu ada suatu keputusan dari diri kita bahwa saya boleh menentukan bahwa saya merasa tidak mampu, itu juga boleh. Tapi bahwa ada altruism, bahwa kita memang harus mengutamakan pasien, kita harus mengutamakan pelayanan kesehatan, tetapi jangan lupa bahwa kita juga harus tetap menjaga diri, menjaga kesehatan kita. Slide berikutnya. Ini saya hanya ingin menggambarkan tentang level of competency in medical care unit, bahwa di Indonesia itu ada 3 pelayanan, ada primary, ada secondary, ada PPK 1, PPK 3. Ini mengacu dari kompetensi di kedokteran, kemudian juga mengacu pada regulasi dari Kementerian Kesehatan bahwa memang ada batasan-batasannya bahwa rumah sakit tipe ABC seperti apa melakukan, kemudian juga disesuaikan bahwa harus tersedia fasilitas pelayanan seperti apa. Inilah yang bisa mengatur bahwa agar supaya semuanya sesuai, baik itu dokternya, baik itu rumah sakitnya, dan tindakan yang dilakukan oleh fasilitas kesehatan tersebut. Ya, selanjutnya slide. Ini tentang hukum, ini tentang Undang-Undang Psikotropika. Undang-Undang Psikotropika ini memang sudah cukup lama, yaitu tahun 97, tetapi bahwa ini tetap masih berlaku, terutama pada pasal 14, bahwa rumah sakit, fasilitas kesehatan masyarakat, fasilitas pelayanan kesehatan, kemudian juga apotek, itu mendistribusikan, atau istilah kalau di dalam hukum ini adalah penyerahan psikotropika, mendistribusikan hanya berdasar resep. Tidak mungkin bahwa psikotropika itu keluar tanpa resep. Kemudian bagaimana mendistribusikan obat-obat psikotropika ini oleh dokter, bahwa dokter praktek hanya boleh memberikan psikotropika suntikan, injeksi. Kemudian menolong dengan kondisi emergensi. Kemudian ada pengecualian, ada klausul. Apabila dokter tersebut bekerja di remote area, di suatu daerah yang terpencil, diperkirakan radius 5 km itu tidak ada apotek, maka sebaiknya ketika kita tahu bahwa kita ditugaskan di tempat tersebut, maka kita minta surat izin menyimpan obat. Ini dikeluarkan oleh Dinas Kesehatan. Jadi kita siap-siap bahwa ketika memang kita bekerja di tempat yang terpencil, itu kita boleh menyimpan obat, baik yang injeksi maupun tablet. Dan dokter pun ketika menyediakan obat-obat psikotropika tersebut harus dari apotek. Slide berikutnya. Ini tentang ketentuan pidana. I'm so sorry, ini tetap pakai bahasa Indonesia karena sangat susah untuk mencoba mendalami bahwa di sini pada pasal 60 ini ingin saya tekankan bahwa apakah yang menyerahkan psikotropika ketika penyerahan psikotropika ini tidak untuk pengobatan dan juga yang menerima penyerahan ini juga sama-sama dianggap bersalah demi hukum dan pidananya sama bahwa 3 tahun dan juga yang menerima 3 tahun. Kalau Bapak Ibu semuanya ingat bahwa saat ini masih bergulir suatu kasus di mana seorang wanita, seorang artis yang menerima obat mungkin hanya 3 tablet katanya, tetapi karena itu tidak berhak dan yang berhak adalah temannya yang katanya mendapatkan dari dokter psikiater di satu tempat. Dan ini saat ini sedang bergulir di persidangan dan jaksa sudah mengajukan tuntutan bahwa si artis tersebut dituntut 3 tahun penjara. Jadi saya kira ini tidak main-main. Di sini kita harus menyampaikan kepada pasien-pasien kita bahwa ketika pasien itu memang berhak mendapatkan obat psikotropika, dia harus menjaganya. Dia tidak boleh memberikan kepada siapapun. Meskipun barangkali bahwa orang yang pernah minum obat tersebut. Tapi jangan sekali-sekali, karena di sini ada ketentuan pidana pada pasal 60, ini sangat mengikat. Meskipun di sini ada klausul, apabila yang menerima penyerahan itu pengguna di sini adalah sama-sama pasien, bukan penyalahguna, bukan gangguan penggunaan, maka dipidana penjara paling lama 3 bulan. Tetapi jangan lupa, di sini tetap dipidana 3 bulan, meskipun bedanya cukup jauh antara 3 tahun dengan 3 bulan. Jadi sebaiknya ketika kita praktek dan ada pasien yang memang mendapat obat psikotropika tablet dari kita, maka kita harus mengedukasi, berikanlah pharmacological counseling bahwa obat ini hanya untuk Bapak, obat ini hanya untuk Ibu. Jangan diberikan kepada siapapun. Slide berikutnya. Di sini tentang mekanisme pengawasan, jadi ada pengawasan bidang etik, pengawasan bidang kompetensi, dan bidang hukum. Kalau bidang etik jelas bahwa baik di ID ataupun di PDSKJI ada MKIK, ada MKPI, di sini akan terus mengawasi bagaimana sejawat-sejawat kita menjalankan etik di dalam pelayanan kesehatan. Kalau terjadi pelanggaran, memang yang paling ringan adalah ditegur saja, kemudian yang lebih berat barangkali akan diberikan surat peringatan. Kalau pelanggaran di bidang kompetensi, ini akan sedikit lebih berat karena di sini akan diajukan ke MKDKI di bidang disiplin board. Ini hukumannya bisa sampai dicabut atau bisa juga dicabut sementara atau bisa dibekukan, baik itu STR ataupun SIP-nya. Tetapi kalau sudah menyangkut pelanggaran hukum, maka polisi ataupun kejaksaan akan bertindak. Di sini bisa sifatnya kriminal, pidana, atau perdata atau sivil. Slide selanjutnya. Jadi barangkali ini harapan bahwa kita berharap obat-obat psikotropika ini di apotek selalu tersedia. Kemudian bisa didistribusikan dengan batas wajar. Memang tidak ada batas angka, tetapi batas kewajaran. Kalau memang memerlukan itu untuk 1 minggu, untuk keperluan 2 minggu, apabila memang dosis kecil dan dia sudah bisa 1 bulan, tentu itu sah-sah saja dokter memberikan sesuai dengan kondisi klinisnya dan barangkali juga dosisnya sudah bisa dipertimbangkan untuk diberikan jangka panjang. Jangan lupa bahwa farmasi apotek harus memberikan obat berdasarkan resep dokter. Dan yang paling diharapkan bahwa apotek ini bisa berfungsi sebagaimana mestinya. Kemudian dari pihak dokter sendiri, bahwa dokter itu harus memberikan obat psikotropika itu berdasarkan indikasi klinik, bukan karena keinginan pasien. Tentu di sini harus diingat bahwa dokter tadi justice, dokter itu otonom, dokter mempunyai kompetensi, bahwa dokterlah yang menentukan indikasi klinis. Kemudian juga dokter memberikan obat itu berdasarkan kompetensinya. Tentu harus dipahami bahwa kalau dokter umum bagaimana memberikannya, hanya batasi dalam beberapa hari saja. Kalau psikiater mungkin bisa lebih lama, kalau psikiater konsultan barangkali bisa lebih panjang lagi. Dan kalau untuk hukum di sini bahwa dispensing obat psikotropika itu hanya di slide-nya ya. Dispensing hanya boleh injeksi saja. Kemudian dari pihak pengawas berharapnya bahwa mengawasi dan memberikan informasi secara standar. Kemudian mengawasi diharapkan tidaklah menakut-nakuti. Pengawasan janganlah sampai mengganggu ketersediaan. Kita tahu bahwa beberapa apotek itu kemudian tidak berani memesan obat psikotropika. Atau apotek itu bahkan ekstrimnya tidak mau lagi menyediakan psikotropika karena seringkali mendapatkan supervisi yang terlalu keras. Dan apabila anggaran dari pihak apotek bahwa sanksi sebaiknya sifatnya juga standar, sanksi itu sesuai dengan guideline sanksi yang ada. Selanjutnya, slide. Ini bagian penutup bahwa marilah kita sebagai dokter ketika kita melakukan pelayanan kesehatan, jagalah moral kita, jagalah martabat kita, bahwa kita sudah dilahirkan sebagai dokter, bekerja secara moral yang tinggi. Kita bekerja sesuai dengan regulasi, kita bekerja sesuai dengan aturan yang sudah ditetapkan. Kemudian kita juga bekerja sesuai dengan kompetensi kita sesuai dengan apa ilmu yang sudah kita pelajari. Dan berikanlah obat-obatan psikotropika itu secara rasional berdasarkan indikasi klinik pasien yang sedang kita hadapi. Sehingga kita tidak akan melakukan pemberian obat yang berlebihan. Moga-moga bermanfaat. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Danardi, for the keynote speech. I believe this is a very important topic these days for the ethical, medical, legal in substance use disorder management. And even though this is a very interesting topic, and I can see some participants have already asked questions for this topic, however, we cannot discuss about this particular topic since this is a keynote speech. but we will try to respond to the question in the Q&A column later. Well, we're going to proceed to our sessions. For this virtual webinar, we are going to have 3 speakers who are going to give talk with different topics. We have the first speaker, Dr. Dia Satya Utami, who will give a talk about substance use disorder and mental health services challenges during pandemic in Indonesia. The second speaker will be Professor Sivakumar Turai Rajasingam from Monash University, Malaysia. Dr. Sivakumar will give a talk on the topic of substance use and mental health disorder comorbidity, management challenges in the pandemic era. And the third talk will be delivered by Dr. Miriam Chiu from the Philippines with the topic psychosocial intervention for mental health comorbidity and substance use disorder. And for participants who all have questions to the speakers, please type your questions in the Q&A column, and we will discuss about the questions and also your responses after all speakers have delivered their presentation. And for Indonesian participants, you can also type the questions in Bahasa. We will translate your question and also discuss in English. Once again, thank you for your understanding that this webinar will be delivered in both English and also Bahasa Indonesia. We noticed that we also have participants from the Philippines. Welcome and thank you for joining our webinar. Without further ado, I will introduce our first speaker in the session, Dr. Dia Satya Utami, SPKJ Mars. Dr. Dia is the president of Indonesian Psychiatric Association. And Dr. Dia is currently the principal trainer in Center of Human Resources Development at the National Narcotics Board Indonesia. And we are very happy to have Dr. Dia, who look very lovely this afternoon with us today. Well, Dr. Dia, the time is yours.
Yeah, thank you, Dr. Fifi Sharif, for introducing me. And good afternoon, especially for our distinguished speaker, Dr. Sivakumar and Dr. Miriam, and also Dr. Danardi. Assalamualaikum warahmatullahi wabarakatuh. So let me delivering my presentation in Bahasa. It maybe make better understand about my presentation. In this afternoon, I will be presenting about the substance use. The topic is about the substance use and mental health. Substance use disorder and mental health services and challenges during pandemic COVID-19 in Indonesia. This is the overview of my presentation. Oh, sorry, I will explain it in Bahasa. Ini adalah overview dari apa yang akan saya sampaikan pada sore hari ini ya, tentang pandemi COVID-19 di Indonesia, dampaknya terhadap komunitas, kemudian juga bagaimana masalah penyalahgunaan nafsa dengan masalah kesehatan mental selama pandemik ini, ya, juga hasil dari satu self examination, ya, swab periksa yang dilakukan oleh Perhimpunan Dokter Spesialis Kedokteran Jiwa atau Indonesian Psychiatric Association. Nanti akan saya gambarkan sedikit hasilnya, kemudian juga bagaimana penyediaan layanan untuk substance use dan mental health di dalam masa pandemik ini, dan juga beberapa tantangan yang dirasakan ketika kita akan memberikan layanan mental health dan substance use di situasi dalam pandemik ini. Nah, kalau kita ingat-ingat bahwa sejak bulan Maret, ya berarti sudah 7 bulan, tahun 2020, persisnya pada tanggal 17 Maret tahun 2020, Presiden Indonesia Bapak Joko Widodo mendeklarasikan bahwa Indonesia sudah mengalami satu pandemi, ya, yang juga dialami secara global dari COVID-19, ya, atau virus corona. Nah, sejak itulah mulai diberlakukan semua protokol kesehatan yang begitu ketat, baik itu berupa fisikal, jaga jarak fisik maupun sosial, kemudian menggunakan masker dan juga mencuci tangan sesering mungkin. Nah, terakhir ini, dalam 3 bulan terakhir ini, kita juga merasakan bahwa ada lonjakan kasus-kasus baru yang meningkat dalam 3 bulan terakhir, yang dimana kita juga melihat bahwa keterbatasan layanan kesehatan juga menimbulkan masalah tersendiri, sehingga banyak fasilitas-fasilitas lain seperti tempat balai pelatihan maupun ruangan-ruangan olahraga yang tidak digunakan terus dikembangkan untuk memberikan layanan kesehatan bagi mereka yang terpapar COVID-19. Dan setiap minggu kita juga mendengar bahwa ada saja dokter yang meninggal dunia atau tenaga kesehatan lainnya yang meninggal dunia, yang seminggu kadang-kadang lebih dari 1 atau 2 orang, ya, dan sampai saat ini bahkan sudah mencapai lebih hampir 130 orang kalau tidak salah, yang terkait dengan masalah COVID-19, ya, baik langsung dari COVID-nya maupun karena adanya penyakit komorbiditas yang mendasarinya. Dan hal lain juga menjadi tantangan kita adalah stigma pada pekerja kesehatan, ya, baik perawat ataupun pegawai lab, petugas laboratorium maupun juga para dokternya, dan semua yang bekerja di bidang kesehatan itu mendapat stigma yang tinggi dari masyarakat maupun juga dari keluarganya, ya, karena dianggap mereka lah yang kontak dengan para pasien COVID-19 yang bisa menularkan menjadi klaster di dalam keluarganya. Jadi ini juga hal yang sangat memprihatinkan buat kita semua, bagaimana beratnya pekerjaan para tenaga kesehatan di Indonesia dan mungkin juga hampir di setiap negara yang mengalami pandemi COVID-19. Nah, kita bisa bedakan bagaimana ini antara, karena kita melayani pasien baik yang itu non-COVID-19 maupun juga pasien dengan COVID-19. Untuk yang mereka yang non-COVID-19 memang sudah ada aturan untuk semuanya ini penerimaan pasien ini dibatasi jumlahnya. Ya, jadi diharapkan bahkan sekarang ini rumah sakit juga membuka untuk mereka harus melakukan pemesanan dulu, ya, untuk bisa membuat appointment dengan dokter yang akan dikunjungi, dan juga ditanyakan apakah memang sangat perlu untuk ketemu dokter tersebut atau memang masih bisa ditunda, ya. Dan kalaupun mereka sudah bisa ketemu dokter, termasuk juga para psikiater, ya, maka konsultasi juga sangat dibatasi, ya, rata-rata maksimum 30 menit untuk bisa berkonsultasi dengan para dokternya, ya. Dan tentunya dengan adanya online consultation konsultasi melalui online ini merupakan suatu cara yang membuat kita lebih optimis untuk bisa membantu para pasien, ya. Terus juga untuk pasien-pasien yang memang mereka sudah stabil dan penyakit kronis, ya, ini ada kriterianya dan ada standar prosedurnya dalam penerimaan. Bahkan untuk pasien yang memang mereka sudah stabil hanya tinggal untuk maintenance ya, bisa diperpanjang pengobatannya. Yang biasanya hanya 1 bulan sekali untuk bisa diulang obatnya, maka termasuk juga dari BPJS Health Insurance itu bisa meningkatkan menjadi 2 bulan sekali untuk kontrol ya. Dan juga bisa menggunakan teleconsultation ya, di mana selain dari pasiennya juga bersama dengan keluarga. Kemudian pada pasien yang dengan COVID-19 ya, di sini kita melihat bahwa pekerjaannya juga begitu banyak ya, bahwa setiap pasien yang memiliki COVID-19 ada satu kewajiban untuk para psikiater atau yang bekerja khususnya terkait dengan kesehatan jiwa, bisa juga psikolog klinis, itu melakukan screening untuk psikopatologi yang ada ya, dan kemungkinan juga adanya resiko-resiko bunuh diri. Karena bagaimanapun kondisi mereka dengan COVID-19 memberikan dampak secara psikologis yang bisa menimbulkan kondisi depresi dan bahkan punya pemikiran atau melakukan percobaan bunuh diri. Dan tentu juga disiapkan berbagai standar prosedur untuk memberikan psikoterapi dan farmakoterapi kepada pasien-pasien yang mengalami COVID-19 ya, terinfeksi COVID-19. Kemudian juga psikoterapi yang dikembangkan secara online, jadi ini juga sudah banyak di berbagai tempat ya, bahkan di rumah sakit jiwa di daerah juga sudah membuka, dan juga banyak profesi-profesi di bidang kesehatan jiwa membuka online psikoterapi. Kemudian juga membuat pedoman-pedoman untuk baik untuk pasien rawat jalan maupun pasien rawat inap ya, dan juga melakukan case conference ya, untuk seperti pertemuan-pertemuan antar multidisiplin ya, untuk membicarakan kasus-kasus tertentu ya, yang juga dibicarakan bersama dengan keluarga, dan menemani atau mendampingi tenaga kesehatan juga mendampingi para klien yang sudah dengan COVID-19 yang sudah memasuki fase-fase akhir atau terminal end stage ya. Ini adalah tugas yang begitu berat bagi tenaga kesehatan, baik itu dokter dari berbagai spesialis, juga tenaga-tenaga kesehatan lainnya, termasuk perawat dan tenaga laboratorium serta tenaga farmasi. Di sini saya gambarkan bagaimana dampaknya terhadap masalah kesehatan jiwa yang terkait dengan COVID-19 ya. Jadi ini juga tadi saya sudah bawakan di dalam acara HKJS ya, bahwa kurangnya pemahaman tentang masalah infeksi tentang COVID-19 ini ya, dan juga menyebabkan kurangnya berperilaku sehat ya, karena tidak paham bahwa masker itu seperti apa sih gunanya, apakah memang benar ia bisa melindungi kita dari infeksi COVID-19. Bahkan ada satu komunitas yang mengatakan bahwa kami adalah komunitas anti masker ya, dan di negara lain seperti Amerika juga masker meskipun diwajibkan tidak menjadi sesuatu yang harus ya, kewajiban. Jadi masih banyak yang tidak menggunakan masker. Bahkan presidennya sendiri sekarang juga sudah terinfeksi bersama ibu kepala negaranya ya, terinfeksi COVID-19. Kemudian juga kurangnya melakukan asesmen dan metode untuk bisa melakukan penilaian terhadap diri sendiri terkait dengan masalah kesehatan jiwa. Kemudian juga masalah ekonomi yang mau tidak mau dirasakan oleh setiap negara yang mengalami pandemi COVID-19 ini. Adanya perubahan dalam pola tidur dan juga pola makan, ya itu juga salah satu yang mempengaruhi kesehatan jiwa, termasuk juga adalah masalah tidur atau kesulitan dalam konsentrasi. Hal lain yang juga bisa terkait dengan saat pandemi ini terhadap kesehatan jiwa adalah adanya suatu tantangan ke depan ya, perubahan-perubahan yang begitu besar ya, yang membuat individu tersebut tidak bisa beradaptasi dengan situasi tersebut. Kemudian juga pengetahuan yang kurang tentang masalah pengetahuan kesehatan baik secara fisik maupun mental, dan juga kurangnya pengetahuan tentang metode bagaimana mengatasi atau coping method dari setiap ketika menghadapi suatu situasi. Dan kita dengar setiap hari dimanapun selalu kita didengung-dengungkan tentang masalah COVID ya, baik itu berupa angka peningkatan kasus, angka kematian ya, dan berbagai kaitan dengan masalah-masalah COVID ya yang ada di sosial media ya, yang kadang juga itu merupakan satu hoax. Tentu ini juga akan mempengaruhi kondisi mental individu. Karantina ya, jadi ini juga banyak yang mengalami suatu ketidaknyamanan ketika mengalami karantina ya, dan mereka seringkali juga sulit dilakukan karantina karena kita tahu bahwa di karantina itu seperti orang yang diisolasi, seperti orang yang memang dijauhi oleh orang-orang lain, yang tentu memberikan dampak secara psikologis ya, sampai bisa menimbulkan kondisi distres, depresi maupun ansietas ya, kecemasan. Dan rasa takut serta cemas ya terhadap kesehatan diri sendiri maupun kesehatan keluarga juga akan mempengaruhi individu tersebut dan menimbulkan masalah-masalah dalam kesehatan mental. Jadi inilah gambaran dari apa yang kita lihat mengapa begitu besarnya masalah COVID-19 ini, pandemi COVID-19 ini terhadap kesehatan mental. Dan tentu juga tidak menutup kemungkinan kondisi kesehatan mental yang terganggu, salah satunya juga kita lihat bisa terjadi peningkatan dari penggunaan narkoba atau nafsa ya, atau drugs. Jadi ini juga menjadi sesuatu yang perlu kita pertimbangkan ya. Mungkin nanti Dr. Siva Kumar akan lebih detail lagi menggambarkan bagaimana kaitannya antara situasi pandemi COVID-19 dengan penggunaan drugs ya atau narkotika. Nah, PDSKJ juga sudah menyiapkan yang namanya swab periksa masalah psikologis ya, di mana kita sudah memulai ini sejak tanggal 5 April. Kita diharapkan bahwa setiap individu yang merasakan ada sesuatu pada dirinya atau bahkan secara umum ingin mengetahui ya, apakah terjadi sesuatu di dalam diri individu tersebut, maka bisa melakukan swab periksa yang sudah disiapkan oleh Persatuan Dokter Kedokteran Jiwa, Spesialis Kedokteran Jiwa Indonesia atau Indonesian Psychiatric Association. Dari sekarang ini sudah sampai 4.000 ya, tadi yang saya baca lagi sudah mencapai 4.044 kalau tidak salah ya. Tapi angkanya tidak bergeser banyak, bahwa memang yang paling tinggi adalah mereka yang merasakan kecemasan ya. Jadi sebagian merasakan kecemasan, kemudian juga ada sampai depresi, bahkan dari angka depresi tersebut sudah sebagian juga, saya lupa presentasinya, tapi mengalami suatu kondisi-kondisi yang menyebabkan punya ide-ide untuk bunuh diri ya, atau berpikir untuk mati saja daripada menderita COVID-19, karena mereka juga merasa ketika mereka terinfeksi COVID-19 mereka dijauhi oleh baik dari komunitas maupun keluarga. Dan 551 orang di sini mengalami satu trauma psikologis ya, akibat ditinggal oleh keluarga secara mendadak, bahkan anggota keluarga yang meninggal kadang-kadang juga lebih dari satu orang ya, atau merasa mengalami satu diskriminatif di dalam mendapatkan situasinya ya, dari komunitas ya, dari masyarakat terhadap apa yang pernah dia lakukan ya. Ini juga bisa terjadi pada survivor dari COVID-19 ya. Indikator dari hasil yang diperoleh tersebut bahwa yang kita lihat di sini adalah terkait dengan mobilitas ya, pengetahuan dan sikap. Jadi memang mobilitas yang ada di berbagai wilayah ini masih cukup tinggi, makanya kita juga sampai sekarang ini masih berlangsung untuk PSBB atau pembatasan mobilitas ya. Kemudian pengetahuan dan sikap perilaku serta produk-produk hukum yang harus disiapkan dalam mengatasi pandemi COVID-19 ya, dan ini sudah dilakukan scoring ya, dari peta scoring ini sudah dibuatkan suatu laporan dan sudah dikirim ke pemerintah ya, dalam hal ini Kementerian Kesehatan ya, sebagai umpan balik untuk membuat satu polisi-polisi tertentu yang terkait dengan pencegahan COVID-19 di Indonesia. Ya, ini gambarannya untuk pasien dengan skor depresi ya. Jadi kita lihat ini di beberapa daerah dengan merah yang cukup tinggi ya di sini. Jadi memang yang masih tertinggi adalah di daerah sekitar Jabodetabek. Oke, dan ternyata dari beberapa hal yang terkait dengan masalah depresi pada pandemi COVID-19 itu adalah yang paling utama adalah kurangnya pemahaman pengetahuan tentang penyakit infeksi itu sendiri, dan kemudian juga usianya ya, usianya justru yang paling tinggi itu usia antara 17-29 tahun, dan juga usia bagi mereka yang lebih dari 60 tahun, sedangkan yang antara 30 sampai 50 tahun itu lebih rendah dibanding kelompok usia 17-29 dan lebih dari 60 tahun. Ternyata perempuan yang lebih banyak mengalami masalah depresi ini dibanding laki-laki, dan pendidikannya lebih tinggi juga lebih banyak mengalami depresi dibanding mereka yang lebih rendah. Kemudian di sini juga didapatkan gambaran pada rata-rata di kota ya, bahwa pada yang usia lebih tua ini skor depresinya lebih rendah dibanding anak-anak muda ya. Jadi memang banyak kasusnya justru anak muda yang biasanya begitu aktif, begitu bisa bersosialisasi dengan banyak ya, dengan sering ya, sekarang harus diam di rumah ya. Kemudian juga pada yang income yang dengan masyarakat ekonomi di bawah, ini transmisi dari COVID-19 cukup tinggi ya. Kalau di Jakarta disebutnya daerah kumis ya, kumuh dan miskin, dan ini tentu sangat berkaitan dengan knowledge ya, pemahaman mereka tentang penyebaran penyakit COVID-19 ya. Dan ternyata komponen dari depresi, ansietas, dan stres itu mempunyai korelasi yang begitu kuat dengan masalah kesehatan mental. Nah, ini kalau kita gambarkan ya, mental health service selama COVID-19, bahwa ya kita menghadapi pasien yang dalam kondisi-kondisi yang memang sudah dalam kondisi jelek ya, dan perlu dilakukan monitor kondisi-kondisi buruk ini. Tentu ini menjadi satu perhatian khusus ya, tentang masalah kesehatan jiwanya ya. Selain itu juga selain kepada pasiennya secara khusus, dalam memberikan edukasi terhadap masalah kesehatan mental juga diberikan pemahaman kepada keluarga ya, baik itu informasi, psikososial support ya, juga bisa dilakukan baik secara onsite ya, face to face, maupun dengan melalui telemedicine. Nah, tentu kita tahu bahwa tenaga kesehatan sendiri juga mengalami banyak tekanan-tekanan dengan situasi pandemi ini, dan mereka juga harus saling mendukung ya, kemudian juga harus melakukan screening secara rutin ya, kemudian juga harus meningkatkan skill-skillnya dalam menata laksana pasien-pasien dengan COVID-19 ya, mereka harus saling mendukung, ada peer support ya, dan juga penggunaan dari personal protective equipment yang harus benar-benar sesuai dengan grade-nya ya, supaya penularannya dapat diminimalisasi. Nah, kita masuk ke dalam masalah COVID-19 dan penggunaan drugs ya. Jadi bahwa bagaimanapun masalah COVID-19 ini merupakan satu tantangan yang besar di dalam satu sistem pelayanan kesehatan ya, secara global, khususnya dalam kesehatan masyarakat ya, dan juga perlu suatu temuan-temuan baru ya, strategi-strategi baru di dalam treatment dan prevention ya, yang diadaptasi akibat dampak dari pandemik ini ya. Dan individu yang mempunyai masalah gangguan penggunaan zat ya, itu merupakan populasi yang punya risiko tinggi ya terkontaminasi, karena terkait beberapa faktor ya yang yang ada pada masalah klinisnya ya, baik secara klinis, psikologikal dan psikososial conditionnya. Jadi kita tahu bahwa pengguna zat atau substance use disorder itu tentu dia selain masalah klinisnya, medisnya ya, akibat penggunaan zatnya, dan juga masalah psikologikalnya maupun psikososialnya akan mempengaruhi atau menurunkan daya tahan tubuh individu tersebut yang kemungkinan mudah akan tertular dari COVID-19. Jadi di sini penting sekali untuk mempertimbangkan ya berbagai grup-grup ya, kelompok-kelompok di dalam subgrup dalam kita memberikan layanan kesehatan bagi mereka yang mengalami gangguan penyalahgunaan zat ya, di mana kita bisa membagi dalam 3 kelompok, pasien dengan penggunaan zat yang sedang ya atau yang rendah ya, yang rendah dengan pasien yang mempunyai masalah gangguan penggunaan zat yang sedang maupun tinggi. Tentu di sini ada perbedaan-perbedaan yang harus kita jadikan ini suatu prosedur dalam penerimaannya ya. Dan kemudian kita juga harus melihat apakah mereka saat ini sudah dalam kondisi yang abstinens atau berhenti dari penggunaan zatnya atau masih aktif menggunakan zatnya ya. Dan juga comorbid psikiatri ya, termasuk di sini penggunaan multiple drugs ya. Mudah-mudahan nanti Dr. Siva Kumar akan lebih detail lagi membicarakan hal-hal tersebut, terutama yang terkait dengan komorbiditas. Nah, ini adalah gambaran bagaimana dampaknya dari setiap zat ya terhadap kerentanan atau faktor risiko seseorang bisa pengguna narkoba atau pengguna zat adiktif bisa mengalami infeksi ya, atau riskan atau berisiko tinggi untuk terkena gangguan terkena infeksi COVID-19 ya. Mulai dari mereka yang perokok berat ya, tentu ada gangguan di respiratorinya ya, di sistem pernafasannya ya, yang dimana juga bisa menimbulkan chronic obstruction pulmonary disease ya. Kemudian juga penurunan dari imunitasnya ya. Dan juga pada susunan saraf pusatnya ada beberapa gangguan-gangguan ya, dan ini tentu semua meningkatkan kemungkinan terjadinya angka kematian ya, meningkatnya tingkat yang berat dari penularan COVID-19 ya, dan juga ada pembengkakan inflamatori atau pembengkakan ya yang terjadi di sistem pernafasan. Begitu juga dengan penggunaan kokain yang mempengaruhi kardiovaskular system ya, ada aritmia, ada mungkin akut myocard infarct ya, dan ada imbalance dari oksigen ya karena gangguan di dalam sistem kardiovaskulernya, penurunan imun sistem ya. Jadi ini kita lihat bahwa semua zat-zat yang terkait dengan masalah penggunaan narkotika ya itu sangat bisa meningkatkan mortalitas atau beratnya infeksi dari COVID-19 ya, itu tentu harus menjadi perhatian kita bersama. Nah, beberapa strategi di dalam pengobatan gangguan penggunaan zat atau substance use disorder pada pandemik ya, ini tentu setiap profesional ya dalam bidang kesehatan, petugas tenaga kesehatan ini harus punya deal ya, punya pemahaman tentang substance use disorder, dan harus memahami bahwa ada resiko-resiko yang dapat terjadi ya pada mereka pengguna zat selama atau bahkan setelah adanya outbreak dari COVID-19 ya, dan juga layanan-layanan atau fasilitas yang memberikan layanan pada adiksi, penderita adiksi ini harus memperkuat ya, dan juga harus diperkuat, dan juga kalau memungkinkan dilakukan postpone dulu untuk perawatannya ya, karena menghindari ya tuh ada komplikasi baik antara substance use disorder-nya dan juga COVID-19, dan juga melindungi penularan coronavirus. Jadi kalau tidak memang bisa ditunda, sebaiknya ditunda untuk perawatannya. Ya, profesional yang juga berhadapan dengan COVID-19 ya, di sisi lain juga harus mempertimbangkan komplikasi yang terjadi pada mereka yang pada substance use disorder ya selama mereka mengobati. Jadi faktor risiko pada tenaga kesehatan dalam mengobati pasien-pasien dengan gangguan penggunaan zat juga harus dipertimbangkan. Ya. Dan juga harus melihat dari mempertimbangkan juga kondisi klinikal, demografik, dan sosioekonomi faktor di mana sekarang ini memang tidak mudah untuk menjangkau atau mendapatkan akses layanan bagi para pengguna narkoba ya untuk menerima layanan masalah penggunaan narkoba tersebut ya. Dan tentu ini di telemedicine ya ini menjadi sesuatu pilihan juga khususnya buat kasus-kasus yang ringan ya, tentu dengan penggunaan APD atau alat pelindung diri yang kuat ya, yang bagus sesuai levelnya ya. Dan setiap fasilitas yang memberikan pelayanan bagi adiksi pengguna narkoba ini harus memperhitungkan ya melakukan pemeriksaan pencegahan ya, dan seperti karantina ya ketika pasien masuk. Jadi ini juga sudah dilakukan yang saya tahu, termasuk juga di pusat rehabilitasi yang ada di BNN, di Lido, dan juga di RSKO yang saya tahu setiap pasien masuk mereka akan mendapatkan karantina 14 hari setelah pemeriksaan rapid test dan diulang lagi ya sampai kita yakin bahwa sudah tidak ada lagi atau hasilnya adalah non reaktif atau bahkan negatif, baru bisa dipindahkan untuk pelayanan substance abuse-nya ya, masalah penggunaan narkotika. Jadi mereka tidak bisa langsung mengikuti program, harus dilakukan karantina dulu selama 14 hari ya. Nah, di Indonesia ini kita kami semua dari Indonesia Psychiatric Association ini sudah membuat guideline ya untuk melakukan bagaimana kita memberikan layanan psikiatri selama pandemik ya, dan juga bagaimana pedoman kita untuk melakukan telemedicine ya, baik untuk mereka yang mengalami gangguan mental maupun gangguan penggunaan zat. Juga bagaimana mereka menjalankan mental health dan psychosocial supporting ini bekerja sama dengan Kementerian Kesehatan dan juga WHO ya, juga membangun beberapa crisis center ya seperti di 119 Extension 8, kemudian melakukan kolaborasi dengan berbagai provider seperti Dokterpedia, Halodoc dan lain-lainnya ya. Kemudian juga memberikan mengimplementasikan protokol dengan sangat ketat ya, dan memberikan layanan yang terintegrasi ya dengan berbagai profesional. Jadi contohnya seperti di Jakarta ini di rumah sakit khusus COVID ya, di rumah sakit di Wisma Atlet ya, kita juga sudah punya tim di sana antara psikiater dengan psikolog klinis ya. Jadi apa menjadi tantangan ya dari masalah tenaga kesehatannya, stigma yang masih begitu tinggi, baik itu dari komunitas maupun dari keluarga ya, bahwa mereka lah penyebar ya, para tenaga kesehatan ini mereka lah yang menyebarkan virus ya di dalam masyarakat, sehingga stigma itu masih begitu kuat. Kemudian burnout dengan pekerjaan yang begitu bertumpuk ya, dan juga tidak jelas kapan akan hilangnya pandemik ini, kapan akan berhentinya pandemik ini, membuat mereka menjadi salah satu yang menyebabkan mereka menjadi burnout dalam melakukan tugas. Kemudian fasilitas yang ada ya, kita tahu masih sangat terbatas dan tidak semuanya juga bisa memenuhi suatu kondisi yang memang benar kita yakini bahwa aman untuk melakukan rawatan atau pelayanan bagi mereka yang mengalami masalah atau melayani infeksi COVID-19. Begitu juga dengan keterampilan. Masih banyak yang keterampilannya dalam menangani kasus COVID-19 dan juga mental health termasuk substance use disorder yang terbatas. Dan training yang pada fase ini juga tidak bisa dilakukan dengan face to face ya, jadi lebih banyak dengan daring yang tentu akan beda ya, khususnya kalau itu terkait dengan keterampilan. Saya rasa demikian yang saya bisa sampaikan. Thank you for your attention. Wassalamualaikum warahmatullahi wabarakatuh.
Terima kasih, Dr. Diah. Thank you, Dr. Diah, for a very fruitful presentation. And to summarize Dr. Diah's presentation, we can see that this COVID-19 pandemic has affected so many aspects, both mental health as well as substance use. And we can see that the quarantine and isolation period affects an increase in the number of mental health issues like anxiety, depression, and also other psychological problems, as well as trends in substance use. And we also see how service providers have challenges in delivering the services. Like the healthcare workers need to use the PPE and also limited facilities, as well as the use of technology. We have to adapt to the situation, and we need to adapt our services using telemedicine and other technology services. Thank you, Dr. Dia. It will be a great discussion for us
You're
later.
welcome.
And we'd like to invite participants to ask questions. So you could type your question in the Q&A column, and we will discuss the questions later with all three speakers. And we are very grateful that until now, all participants are still active and involved in this webinar. Now we have approximately 500 participants, mostly from Indonesia and also participants from the Philippines. And hopefully you all are going to stay alert and stay until the end of the webinar, because we will have a post test for you to be required to get ED certificate. This is especially for Indonesian doctors who will get a credit from the organization. We are going to proceed to our second speaker. The second talk will be given by Dr. Siva Kumar Turai Rajasingam. For the host, could you please share the curriculum vitae of Dr. Siva Kumar? Dr. Siva Kumar Turai Rajasingam is a consultant psychiatrist and an associate professor at the School of Medicine and Health Sciences at the Monash University, Malaysia. Dr. Siva Kumar is also a certified trainer at the Asian Center for Certification and Education of Addiction Professionals, ACCE, UTC for Substance Use Disorder, Colombo Plan, and also a certified national trainer for the National Assisted Treatment Program for Opioid Dependence. For this afternoon, Dr. Siva Kumar will talk about substance use disorder and mental health comorbidity, as well as the challenges in the management of this comorbidity of mental health and also substance use disorder. Dr. Siva Kumar, the time is yours.
Thank you, Dr. Vivi.
Thank you.
Well, first and foremost, I'd like to thank the organizers, Abipraya Foundation and the Indonesian Psychiatric Association for giving me this opportunity to talk a little bit on substance use and mental health disorder comorbidity, basically about some of the challenges that we are facing in the pandemic era. I apologize, I'll be speaking in English. I can talk Malay, but mine will be Bahasa Malaysia, and that may be a confusion for some. And of course, the people from the Philippines will not understand at all. But of course, I'm quite open later on to discuss it later, any questions or anything. What I'm going to talk about here is I'm just going to give you a small introduction into the comorbidity that we have around the world, and then go basically into some of the issues that we have seen actually for the past 6 months or so when the pandemic actually started. And some of the issues basically have been touched very clearly by the speakers earlier. And loneliness, quarantine are all big issues, but I'm just going to tie it down and show you how those issues are connected to drug use and mental health. Now, co-occurring disorders, comorbidity, it's got lots of words. Some people call it as dual diagnosis, but basically what does it mean? It basically means that it's when one or more substance use occurs together with a mental health condition in the same person at the same time. So a person can have an alcohol use disorder with depression, but it does not need to be a mental health disorder when you talk about comorbidity. Comorbidity can also be physical health, like whenever a person is drinking, he can have depression, and he can also have liver problems, cirrhosis, hepatitis. So there is a whole range of people whom we actually call co-occurring comorbidity and dual diagnosis. Now, how common is this? Now, when you look at it separately, mental health and substance use disorder, you find that a huge number of people are basically involved. When you look at readings and reports from the Global Burden of Disease, you find that almost more than 970 million people have a mental health disorder, and about 15 to 39 million, basically use a lot of illicit substance. But what we are talking about is the group of people who use both together, and how common is that? So when you actually look at this easy chart, it basically shows that about 50% of those with a substance use disorder also have a mental health disorder. So we're talking about half. So if you have in your hospital about 50 patients who use drugs, you can almost easily say that 50% or more are using substances. And you find that a lot of them basically mix and use. And there are so many reasons why there is a mixture and why they use. What you find is when you look at co-occurring disorders, the rates of abuse and dependence is more often higher in males than females. Now, we really don't know what the reason is. It may be due to reporting errors, or it may be due to the availability of drugs, or it just may be the different built up of males and females. But we see certain differences in each gender. The males are presenting a lot with personality disorders like antisocial. But whereas the females, they present more on mood disorders, anxiety. So when you actually looked at the presenters before, you find that, it's true, it does make some sense that actually females do score high or are more recurrent presenting with mood, depression, and anxiety disorders. Now, how common are these actually? So when you look at this, this is a study which was published in Australia and New Zealand. You find that among the males, although the use of substance is actually quite high compared to the females, but you find that the females score high when it comes to affective symptoms, that is mood symptoms, and also anxiety. When you look at the whole picture, you find that there is a lot of overlapping. There's a lot of overlapping of mood symptoms, anxiety symptoms, personality symptoms with substance use. And there's a very close link. Why is it a problem? Why is it a problem? It's because it brings about a lot of problems or difficulties to us. One is, this group of people are basically people who use drugs more severely. Because of the underlying mental problem, they use drugs. This group of people are at high risk of self-harm and suicide. If you were to compare someone without a mental health problem against a person with a mental health problem and uses substance, you find that they are more risky. They are at risk higher. You always find them in the poorer sector of economy. They are poorer in terms of health. They are homeless. As I said, they have an increased risk of violence. There's a lot of stress. Already, even before the pandemic, there was a lot of stress, especially being accepted, the family, friends. And generally, this was a group of people who had very poor social and occupational functioning. Why do comorbidity occur? Now, this is very important to understand because the pandemic has actually brought about a lot of links and why it is actually higher in the pandemic than anywhere else. One is, it could be due to a direct causal hypothesis. Direct means it is directly from the mental health issue. Like, for example, someone who is depressed, who has lots of mood symptoms, a lot of anxiety, would actually go and choose a drug which helps him or her. So something that calms you down, something that gives you a bit more sleep. And normally many of them choose depressants like alcohol and benzos. Another example of a direct causal hypothesis is a person with ADHD. You find that they've got problem with attention deficit, they can't focus. They will look for a drug which can help them with focus. And obviously they go for stimulants like methamphetamine. So that's the direct causal hypothesis. There is also something called as indirect causal hypothesis, where the use of drug is indirectly caused by the substance. A small example that I can give you is, you normally find that people who use drugs early in their years, they basically drop out from school, they can't find job, they are unemployed, they have got problems with housing, with money. And normally you find that this group of people basically are more prone for depression. So it's not direct, it's an indirect causal relationship. And the third one is, of course, something called as common factors. There is one thing that is quite common to both substance use and mental health problem, that is genetics. That is something that is very common. So you find that there are certain areas in the gene makeup that actually puts a person more prone for both substance use and mental health problems. So these are reasons why it can actually occur. When you want to look at a mutual relationship between the substance use and mental health problem, you find that alcohol and other drug use sometimes help people with mental health symptoms. Now, I used to work in a huge psychiatric institution. And so you find that a lot, the reason why we find that a lot of our inmates actually smoke. And we were asking why, what's the reason why they smoke? And we actually found out that, through research, it's clearly also stated that the illness itself or the medication that we use basically numbs certain chemicals in the brain. And for them to stimulate their mind or stimulate the cognition, the mind, they smoke because the nicotine actually stimulates the mind. So just like that, whenever they use, they find relief, but that is only temporary. So they have to use again, and then they find relief, they stop, they use again. And so it goes on. It's like a love-hate relationship. They need it sometimes, they can't stop it. We understand from research that there's a lot of impact, especially when you start using drugs early. And that's one that we have actually found, that during the pandemic, a lot of people have actually started using drugs early. We know from research for sure that early substance use is always a risk for later worsening of substance use. And that's the reason why in many countries, including Indonesia, Malaysia, and in the region, we say that it's best to avoid starting substances. Sometimes we even talk about smoking as a gateway drug to other drugs, because when they are exposed to it early, the chances of being falling into the drug substance use problem is higher later on. An amazing thing is, it also shows that if you start your substance use early, you are at a higher risk for mental health disorders later on. And that can be proven by the use of cannabis at an early age, where later on they have mental health problems like psychosis, schizophrenia. And these are things which are all backed by research. Now, challenges of co-occurring disorders. As I said, they are always a more difficult population to treat. The reason is because there is always negative effects on both treatment, both for substance use and mental health disorders. They are not easy to treat because they are relapsing, remitting conditions. Second, you find that clients with co-occurring substance use disorder and mental health have less adequate relationships. So the network is already not there, and which actually got worse during pandemic. The social supports were very weak and not there. And they also had huge problems in terms of housing, employment, and income. So let me move to the pandemic. Now, the same problem that Indonesia is going through, Malaysia went through. We thought we were getting better, but I think of late our numbers are also going up. And there were a lot of issues that came in. Initially, when we had huge numbers, we shut down. And there was a lot of social isolation, there was quarantine. Now, the word quarantine was never thought of as a big thing, but I'm going to show you the connection between social isolation, quarantine, and mental disorder plus substance use. Now, what happened is, in quarantine, a lot of things actually happen. The duration is long. There is a huge impact on information. A lot of people don't get information. A lot of people lose jobs. There's a lot of stigma. I think our speakers have already spoken to you about it. So some of the challenges that has changed in the pandemic area when we're treating this population is the population that was always a problematic population became more socially isolated. We found that there was a lot of social isolation, and I'll show you the connection between social isolation and health. A lot of them lost their job, then it led to self-reliance lack. People who actually had coping mechanisms, people who went for meeting, NA meeting, AA meeting, suddenly stopped going for meetings because meetings couldn't be going on. So there was a stop in their coping mechanisms and they didn't know how to deal with it. There was a loss in the structure in life because they had to stay at home, they had to do things differently. And these are a group of people who find things, learning new things difficult. Stress became a huge thing. Access to treatment. A lot of them couldn't go to hospitals. A lot of them couldn't actually go to clinics because of the shutdown and other issues. Now, let me give you a connection between how social isolation affects health. Now, there's a huge word that people always use, loneliness. Now, what is loneliness? Because we use it left and right. Many ways to define loneliness, So loneliness is normally generally defined as people's level of satisfaction with how well they connect with friends, family, and your network. Or there is something called perceived social isolation. That means you feel that you are isolated, all right? Now, surprisingly, whether you believe it or not, isolation has got lots of research. Now, I didn't know that myself. And when the pandemic came and I needed to talk and I needed to, even before this, to explain things to people, I actually looked up and I found that there were lots of research that actually goes on isolation. And it's very strongly linked to depression, very strongly linked to anxiety, and also cognitive problem or thinking problem, memory problem. Some of the main reasons why is it makes people weak. So your resilience means kekuatan diri. So your resilience comes less. People feel they are not worthy, self-worth goes down. Because they're not going out and they're not working, they're not talking to people, they feel that there is no purpose in life. So sense of purpose actually comes down. And the feeling of being valued also comes down. The research actually shows that the lack of social connectiveness is got a very close link to health. If you have a lack of social connectiveness, it is as bad as smoking 15 cigarettes a day to your health, or having an alcohol use disorder, and twice as harmful to your physical and mental health as obesity, just by having a lack of social connectiveness. People who sit down, don't meet people, don't talk, your health condition is as worse as smoking 15 cigarettes a day. Loneliness is also linked with the risk of stroke, about 30% increase of stroke, and also coronary heart disease, a very close this thing. It also increases the risk of premature death for every cause. And amazingly, 40% increase in a person's risk to dementia. So that's how strong social connectiveness is. All right. Now I'm going to show you what's the link between social isolation and health. Okay. Now don't get confused by this chart. Okay. You don't have to read it. I find it difficult to read it myself, but it looks nice there. What it does actually, there is when a person is socially isolated, there's a lot of changes that happens. It's not only mood, it's not only emotions, it is also deeper parts in your body, especially the cells. Especially the cells. What happens is they've got proof that lonely participants or lonely people who basically don't mix around, they find that their white cells, especially the leukocytes, increases, and there is a lot of inflammation. That means it becomes higher than normal. And inflammation is something that's always been tied very closely to depression. So what they actually found out was people who had this close connection of social isolation, mental health problems, and depression and substance use had changes in their cell counts, and the changes in the cell counts was not due to the depression or the substance use. It was actually due to the perceived social isolation, the behavioral changes. So social isolation by itself can actually worsen your mental health condition and leading to a worsening or a beginning of a substance use disorder. So that's how close it is connected. Social isolation in quarantine plays a huge part. And that's the reason why, even in Indonesia, you're seeing your statistics high. And that's quite proven. Now, how does it actually affect addiction? Studies that showed, that looked into addiction problems basically saw the largest growth of alcohol sales in the US. This is by the National Association of Drug Abuse and Alcoholism. They actually found that this was the time during the pandemic, there was the largest growth of alcohol sales. In UK, it was the same. Alcohol sales rose by 22% in March 2020. And a lot of other things opened up. It may not be so much in the Southeast Asian countries, but in other places. And my neighbor, I'm basically in Malaysia, in Johor Bahru, in Singapore, they opened up a lot of things. Something called as, I don't know how many of you have heard of what a virtual bar is. You've heard of virtual conferences, you've heard of virtual teaching, virtual consultation, virtual bar. This is something new, all right? So what is a virtual bar? It basically is where you actually get that feeling, that sensation, you're in a bar, and you pay, and you pay, or something like you pay for a drink first, and then you drink later. That means whenever it's open, they will send it to you. And this was also a time where you found that a lot of youngsters, there's lots of data which shows that people as young as below 12 years started abusing drugs, and it was more open. And because of all the changes that actually has been taking place. Some of the reasons why people turn to substances in this field is it is as a coping mechanism to numb emotions. People just didn't know what to do. People lost relationships. You just couldn't go out. You couldn't talk. So people used it as a substitute. A lot of people basically didn't know how to deal with stress. A lot of people that I knew that were under my treatment used to go for meetings and NA meetings and self-care help groups, So that was their coping tool. When they suddenly lost everything, they didn't know how to deal with stress. And the only thing that they knew was substance use. Self-efficacy brought in a lot of emotions, a lot of depression, a lot of suicidal ideas, and people turned to addiction to actually cover this. Now, some research during this phase of time also basically found that youngsters who actually turn to drugs at an early stage are actually more vulnerable to using it for a longer period of time. Because what it does is, these are basically research in animals that shows that the earlier you start using drugs, as I said, the rate of youngsters using substances have increased. The earlier you use drugs makes your brain system more prone to actually use it longer. That means you are more resistant to stopping the drug. You can't stop. You have to go on using. And that is another fear that we have, that we are starting to see substance users at an early age. And as I told you, the earlier you start substance use, you know you are at risk for a mental health problem. Now let's talk about psychiatric illnesses. Okay, what's the isolation on psychiatric social isolation's effect? Now this is a very new study published in April 2020, which looked at a whole group of people who basically came in for a checkup, and you found that there was a huge mixture of people who basically presented with anxiety, with depression, and they had very poor functioning. And amazingly, most of these people with anxiety and depression and poor functioning turned to substances. Some of the highest substances that they used to use was alcohol and other drugs like cannabis, and depending on the place where research was done, to overcome all these issues. Now, some of the reasons that people gave why they actually turned to drugs was because they didn't know how to cope with illness. They didn't know how to cope with the change. They didn't know how to cope with that loss of structure in life. You know, they were doing things differently and now they didn't know what exactly to do. Stress is a huge thing and self-reliance a huge thing. I run a psychiatric clinic with comorbid mental illness, and I've had quite an increased number of clients who were stable, who actually went back to substances because they didn't know what to do. I had one chap who was working in Singapore. So he used to travel from Johor Bahru to Singapore. It's just across the border every day. And he used to work well. He used to have a substance use problem, alcohol. He stopped because he was working. His day was packed. He had a structure in life and he felt useful. But when the borders closed, now we cannot go into Singapore and Singaporeans can't come into Malaysia. He was at home. And he didn't know what to do. Basically, he didn't know what to do, and he had to turn to alcohol. And there's a relapse. Now, there is also a very close relationship between unemployment and mental health problems. You find that suicides associated with unemployment is actually 9 times higher than any suicide due to an economic crisis. So you find that there is an acute rise in unemployment currently, and that rise of unemployment has led to an increase in suicides. And they have found that it's actually non-linear. So what they're trying to say is, though people have lost their jobs now, you won't see the number of suicides going up now. You will only see it a few months down because it takes some time for it to hit them. A mental health problem comes in, substance use, and suicide. And there's a lot of substance use here. So this is just the impact of what unemployment and suicide is. Unemployment has done. You know, you find that the highest rate scenario is there has been almost 24.7 million jobs lost. And each suicide in a population is actually accompanied by more than 20 suicide attempts. Although we see a lot of suicides, but there's lots more suicide attempts in the population that we don't see. And a lot of this are closely connected to substance use. The reason is because substance sometimes in a way helps people attempt suicide. So it sort of cuts down your inhibition and allows you. So having to look at this, there's a huge connection between being quarantined, being lonely, its connection between substance use and a terribly increasing rise in mental health problems. So the problem has not stopped. When I was talking to Dr. Bibi just now, we were saying that, I hope that it will go off and we'll be okay by the end of the year. Guys, the truth is things are not going to stop. things are only getting worse in many places we see, although we keep our fingers crossed, but that's not how it's going to be. It's going to be here for a long time. So we are starting to say, rather than keeping our fingers crossed and praying that it will stop, yeah, we do that. But what we have to do is we have to change the way we do things. I think the world has changed. It most probably will never be the same again. So we're going to do things differently. We're going to teach differently. We're going to treat people differently. So a lot of things needs to be done. And I think a lot of things that have been also done in Indonesia, and I'm quite happy and proud to see that a lot of changes. Some things that can be done is the access to treatment. They find that this group of people, especially when you're talking about people with a comorbid problem, are always people who are poorer in the lowest socioeconomic sectors. And when you are in a lockdown, it's going to cut down a lot of access to treatment. I'm happy to hear that a lot of teleconferencing is going on, a lot of consultation is going on, and I think that's the only way to go, But then again, to reach out to this group of people, do they have that access to internet, to the availability of technology, Another thing that should be brought in is psychosocial intervention. I think those interventions must be brought in, and that needs to be strengthened. And I think the next speaker will be speaking more on that. Drug abuse, substance abuse, mental health problem, the starting point is only treating it and identifying it. But there's a lot of structure problems, even in substance use disorder. The structure in life is so important, how they lead their life. And the same for mental health problem. So that's where there is a lot of similarity. So we've got to look into how we can actually work with the structure in life, how to help with resilience, making people stronger, how to work with coping mechanisms in life, improving communication, a lot of stigma, a lot of uncertainties, fears that people have. Many places have actually started reaching out to clients. If you can't come to me, I'll come to you. So outreach is something that we have to start looking at, and how we can actually reach out to the most at-risk communities. And of course, most important, and I think even before this, Dr. Dia had also stressed, is we look at clients, we look at our patients, but we tend to forget about ourselves. And I think that was a big, huge problem here in Malaysia also. Neglected the doctors, the healthcare workers. Now, these are people that should be looked into. So not only our clients get depressed or anxious and use drugs, but sometimes even our healthcare workers can turn to that. So with that, I'd like to thank you. Open to any questions later on. Thank you.
Thank you so much, Dr. Siva Kumar. It was a very great presentation, and we can see how the pandemic affects the mental health as well as the substance use disorder, especially when you brought up the issue about social isolation. It's very interesting that there have been so many studies related to social isolation and mental health. And it seems that, like what Dr. Siva has said, the world has changed, and now we have to adapt to this new situation. We have to build more resilience to ourselves and learn new coping mechanisms. And that's also what we need to do with our patients and clients. Thank you so much. And we are going to discuss more about this later in the discussion session. And for participants, we would like to thank participants who have been typing the questions for our speakers, and we will discuss about it in the discussion session later. And thank you for staying with us. We are going to proceed to our third speaker. Previously, Dr. Siva Kumar also said about psychosocial intervention, and the third speaker will talk more about this, especially psychosocial intervention for mental health and also substance use disorder comorbidity. Our third speaker is Dr. Miriam Q. Miriam Q, PhD, is the chairperson of the Professional Regulatory Board of Psychology in the Philippines. Dr. Miriam Q is also a consulting clinical psychologist and the Director of Psychological Services at the New Day Recovery Center in Philippines. And Dr. Miriam Q is the country's first registered and licensed psychologist. So we expect to learn a lot from Dr. Miriam Q about psychosocial intervention for mental health and substance use disorder comorbidity. Dr. Miriam Q, the time is yours. It seems that we are still not connected to Dr. Q. There we go. Dr. Miriam Q, glad to have you here with us.
Okay, thank you
Thank
very
you.
much. Good afternoon, everyone, or it's already evening here in the Philippines. So good evening, friends, colleagues, students. I am very privileged to be with you this afternoon, to be part of what Dr. Risa considered a milestone endeavor. I am very privileged to be with very renowned psychiatrists, great speakers like Dr. Danardi, Dr. Dia, and Dr. Siva. And this is actually an opportune moment for a reunion with this great psychiatrist virtually. So my thanks to the host, our host, the Abrifaya Foundation. So my talk is all about comorbidity, comorbid conditions, and psychosocial intervention, okay, for mental health comorbidity and substance use. Now, Dr. Siva already discussed what comorbidity is all about. Okay, so let me just sum up what he mentioned earlier, that mental health and substance use disorders are prevalent and highly disabling. So it is a cause for alarm, a serious public health concern. Morbidity and mortality is very high. So for comorbidities. Now, one thing we need to understand is that comorbidity of any type, unless it is addressed, actually leads to reduced compliance with medication, greater disability, and poorer chance of recovery. Many of our clients, our patients would say, I don't really need medication. I don't want to take any medicines. But truth is, pharmaceutical treatment, pharmacotherapy, medication is important to stabilize the system, to stabilize any imbalance in brain chemistry. Now, we know, however, that medication is not a standalone treatment if we talk about therapeutic effectiveness. And so is psychotherapy or psychosocial interventions. So in the case of comorbidities in particular, it is a very integrated treatment is a very important. Now, another issue is that while a wide variety of psychosocial interventions play a major role in the treatment of mental health and substance use conditions, okay, their therapeutic effectiveness have been demonstrated, but it is rarely used in clinical practice. And there is still a lot of concern where therapeutic effectiveness, the measures of therapeutic effectiveness are concerned. So basically, Our issue now is that there is yet no standard system in place to ensure that the psychosocial interventions we deliver to our clients are truly effective. So I would challenge our researchers, research colleagues to look into this fact, looking into the effectiveness of our psychosocial interventions. Okay,
Excuse me,
now,
Dr. Miriam.
yes,
Could you please click the slideshow item there so we could see the slide in slideshow mode?
where is? It's already in slideshow mode.
Oh, it's already in slideshow mode.
Yeah, I don't know. Or should I get out so you can? Is that okay?
No, it's still fine. But if you could change it to slideshow mode, it will be
This is
shown
slideshow.
clearer. Okay,
Can
then.
you? Huh? Can you see me?
Yes, we can see.
Okay,
Yeah, we can see.
I mean, I can. Can you see the slideshow? Okay.
Yes. Okay. So please
So
continue.
there is yet, my apologies. So
No
there
problem.
is yet no standard system in place to ensure that psychological interventions we deliver to our patients are that effective. And this we will discuss later. So the concept of comorbidity has already been explained by Dr. Siva, whom I respect, truly respect, and that it is a term actually used to describe a mental disorder co-occurring with a substance use disorder, or the comorbidity would actually be with a medical disorder. So a comorbidity exists when one type of disorder is established to be independent of another disorder. So as Dr. Siva mentioned earlier, it's not just a cluster of symptoms from a particular disorder. So comorbidities actually refer to overlapping disorders. So many terms have actually been used in history. MICA, the mentally ill, chemical abuser, okay, the chemically addicted and mentally ill, okay, dual diagnosis, but more recently, we refer to this as co-occurring disorders. And in the case of mental health disorders and as SUD, we have what we call as co-occurring mental disorders. Now, SUD, this has already been mentioned also by Dr. Siva, that SUDs are highly comorbid with mental health conditions. Now, but research evidence suggests that the highest association is with borderline and antisocial personality disorder, bipolar disorder, schizophrenia, and depression and anxiety disorders. Dr. Dia also mentioned about co-occurring medical conditions, and she explained how COPD and cardiovascular disease puts at risk the SUD, the substance use disorder per patient, how at risk he is during this pandemic because of his vulnerability to respiratory illness. Now, again, it was mentioned that by my esteemed psychiatrist, Dr. Siva, that patients with dual diagnosis have high rates of mortality and morbidity. Now, so to address this problem, okay, we have to manage dual diagnosis or comorbidities or co-occurring disorders. First, we use pharmacological treatment. Okay, so it is the mainstay for drug treatment of psychiatric illness. And this includes the use of mood stabilizer, antipsychotics, antidepressants, benzo, anxiety drugs. So Now, the second, it also includes the non-pharmacological treatment. And this is where psychosocial interventions come in. And these psychosocial treatments include family interventions, motivational interviewing, motivational enhancement therapy, relapse prevention counseling, contingency management, cognitive behavior therapies, and other behavior therapies, either alone or in combination with other treatments, okay? So, but newer therapies include stress reduction and relaxation techniques, mindfulness, and all these things. But of course, we also have somatic treatments, which are now least commonly used except for biofeedback for anxiety. Now, how does, psychosocial intervention, it's rather a mouthful, psychological and social. So let's have a common understanding first of what intervention is all about. So the dictionary defines intervention as a method of interfering with the outcome or course of a particular condition or process. Goal is to prevent harm or to prevent functioning. Okay. Now, it is also an intentional action, okay, meant to interfere with a particular event or a condition to affect its course, its issue or outcome. So if you look at these definitions, two constructs are of great concern: the action itself of intervention and the outcome of the intervention. So that's intervention. Now, psychosocial interventions actually capitalize on psychological or social actions. That's why psychosocial, psychological, or social actions to produce change in psychological, okay, social, biological, or functional outcomes.
So, Miriam, I think
yes.
the slide is a little bit stuck. Are you on the fourth slide? We are still seeing the third.
Psychosocial intervention.
Oh, we are still seeing the third slide, the concept of comorbidity.
So I don't know who's presenting the slide, your the IT group or me, because I'm already in the sixth slide.
For this moment, you are the one who present the slides.
Yes.
But we are seeing the third slide now. We're not seeing the,
okay. Okay. I'll give you our approve. I'll approve a remote control of the screen. Okay.
Okay, I will ask the host to help for screen share.
Psychosocial intervention.
Okay.
Oh.
We will try to help screen share for you.
There's.
So you are on the
actually
sixth slide?
On the ninth.
Oh, the ninth slide.
Okay, yeah.
Okay. So now we can already see the ninth slide, the psychosocial intervention.
Can I I'll just proceed.
I think you can proceed. Yes, thank you.
I can see it from my end. Yes. So intervention has to do with intervention emphasizes two constructs: action and outcome. And psychosocial interventions capitalize on psychological or social actions. Thus, the term psychosocial to produce a change in psychological, social, biological, and functional outcomes. So the emphasis now in here, okay, would include the mediators, okay, the settings. First would be the setting, and the mediators, or the way in which the action leads to an outcome, as a way of distinguishing psychosocial from other interventions, or like medical interventions. So there is a mediator who will facilitate the change to produce the needed outcome. Okay, now, okay, so now there are psychosocial interventions actually for mental health and substance abuse disorders are considered informational activities like psychoeducation, or interpersonal activities, techniques or strategies, okay, like psychotherapeutic interventions that target behavioral, cognitive, emotional, and all these factors. Now, we should bear in mind, however, that there is yet no widely accepted categorization of psychosocial interventions, because all these activities are applied to a broad range of interventions, which includes different forms of psychotherapies, or it could include community-based treatment, okay, like assertive community treatment, first episode psychosis interventions, or it could include vocational rehabilitation to facilitate re-entry or reintegration of the person into the community. Dr. Siva was mentioning earlier that employment and unemployment is actually a significant factor in attaining mental health. So vocational rehabilitation, it would be needed to help the person with SUD and the other co-occurring disorders to be reintegrated into the community. So this would call for livelihood program, okay, and employment skills. We need to increase his employability. Peer support services are also in order, along with integrated care interventions. Okay, now, aside from this, so we mentioned, so psychological interventions, as mentioned earlier, includes the intervention activities, those techniques or strategies delivered interpersonally or through educational means or information. Now, these intervention activities are expected to create, to speed up or facilitate a change process which would make it possible for the desired outcome to happen. So the change process would include changes in the biological, cognitive, emotional, interpersonal, or social areas, and the desired outcome in functioning needs to be seen in terms of symptom reduction and all that. So now, if we look into intervention activities, okay, we have what we consider as general social interventions. This is generic, common to all effective psychosocial interventions. And this involves therapeutic alliance, the relationship between the patient and the mediator or provider of the intervention, okay, along with the different psychotherapies like motivational enhancement therapy, cognitive therapy, psychodynamic therapy, interpersonal psychotherapy. Okay, so these are general psychosocial interventions. Now, as we move on to the specific, these are for distinct populations, distinct targets using specific activities, like group therapy for bipolar disorder, support groups for those who have bipolar disorders and substance use, psychotic disorders, specific social therapies like modified cognitive behavior therapy, early recovery programs, adherence therapy, self-help groups, recovery programs. All these are specific interventions targeting specific areas of functioning. Now, when we speak of outcomes, okay, so these are the desired outcomes in functioning and well-being. Now, this includes symptom reduction. So, the physical and mental health symptoms, okay? Outcomes can also be considered in the context of the individual's functioning, okay? His day-to-day tasks, including physical activity, participation in school or work, maintaining relationships with other people, involvement with community activities, okay? We say that mental health, it has to do with well-being. The person's capacity to develop himself, work productively and effectively, build relationships and make connections despite the circumstances he may be in. Okay, so it includes managing the day-to-day stresses. Now, when a person has SUD, substance use disorder, more so if it is comorbid with a severe psychiatric condition, now functioning may be impaired. So when we measure outcomes of intervention or look into the outcomes of psychosocial intervention, we look into the individual's basic functioning, not just symptom reduction, okay? And of course, his well-being may be a bit difficult to measure. His spirituality, life satisfaction, quality of life, recovery, his self-efficacy and self-determination alongside his perception of his life and of quality care, okay? So we look again, when we talk about psychosocial intervention, we look into the activities used for intervention, the process, the change process, which could bring about the desired outcome. Now, the management of patients with dual diagnosis is quite a challenge, okay? Because we know that a lack of improvement in one disorder, okay, can lead to a relapse of both disorders. That's why they have to be managed altogether. That's why we now talk about integrated care management, okay, so that both disorders are addressed, knowing that if one is not addressed, it can cause a relapse in the other or in both, or a worsening of both disorders. Now, we also know that comorbidity can actually alter the course of treatment, the course of the illness, the treatment, and its outcome. That's why psychosocial interventions, just like medication, has to be individualized as much as possible. That's why we talk about individual-centered care, patient-centered care, client-centered care, because the comorbidities may be different as much as the severity of the disorder also differs. Now, comorbidity is associated with significant mortality, as we mentioned earlier, and morbidity, hence can worsen actually functional impairment. Now, the challenge now is that while we are aware that psychosocial interventions are very beneficial, these interventions are very difficult to implement. It's sometimes we think it's easy, but actually it's very difficult to implement because psychosocial interventions require, first and foremost, teamwork. Okay, people need to work together, providers need to work together, and this would involve professionals other than psychiatrists and psychologists alone, the social workers, the peer specialists or support groups, lay people, the church, sometimes they come in. Okay, so the community at large. Now, aside from teamwork, the program or the program for psychosocial intervention must be wide. It should be comprehensive, at the same time individualized. That's quite a challenge. How you can work out an intervention program that cuts across a wide range of individuals, a wide range of vulnerabilities and disorders, at the same time highly individualized to meet the specific needs of every patient. And to a large extent, it requires training to various levels that is difficult to achieve in many settings. Okay, people talk of cognitive behavior therapy as if they really have complete mastery of the subject matter. But then when they really are, when you observe them doing CBT, which we consider for CBT, for instance, which we consider evidence-based. So there is evidence to support that CBT is effective. But what about the provider, the staff who provides the method? Is he trained enough? Does he have competency of the subject matter or the use of the method he is using? So these are concerns which we need to look into. That's why training is very important. Competence is very important. Dr. Denarde mentioned earlier that a doctor is given authority to practice in the context of his competency level. So too with the different forms of psychosocial interventions. Okay. Now, there are 5 things nonetheless we should look into when we talk about providing psychosocial treatment for patients with co-occurring disorders or comorbidities. Okay, first, we have to understand that during the engagement process, we need to develop a supportive therapeutic alliance. Okay, now develop alliance. Many times we are in counseling, we say develop rapport. Now in the context of motivational interviewing, we say provide a wholesome environment that will minimize or address resistance. Now we say that there is no such construct for a psychological construct for resistance, meaning there is no person who is considered as resistant. So resistance, therefore, has to do with the relationship between the therapist and the patient. Now, for therapeutic effectiveness, we need to minimize, reduce, or not zero in that particular discord, which may be the cause of the resistance. So motivational enhancement approaches may be very helpful during the engagement period. There is nothing a psychiatrist or a psychologist or any mental health provider can do unless, no matter how good he is with the therapeutic techniques, unless the client is engaged in the treatment program. So engagement is very important. And during the engagement process, We have to develop and strengthen the supportive and support the therapeutic relationship or the therapeutic alliance. I remember the late David Powell, who used to tell me, Miriam, it's not technique that matters, but if you look at the effectiveness of various psychotherapeutic interventions, what matters most is the relationship, the therapeutic alliance. Okay, so now granting that the therapeutic alliance has already been established, okay, during this engagement process, we now need to look into evidence-based treatment approaches for different illnesses to formulate an individualized treatment plan. Many people talk about, many providers, mental health providers, talk about eclectic therapy. But my understanding of eclectic therapy, meaning you combine different techniques, which I consider impossible unless you have a mastery of each and every technique you have combined or put together. So mastery for each technique is very important. Proper competence in each therapeutic approach is very important before you can mix different approaches to address a particular management action, treatment program for any particular patient or client. And this also calls for assessment. Assessment of the situation, assess the client situation, assessment of each particular disorder the client is experiencing. Assessment, as we all know, tells us where the client is, where he has been, and that is very important for us to know how to guide him to where he wants to be. Okay, Dr. Risa is very good at this because we have been training together on this issue. So help the patient, okay, another key principle, help your patient acquire skills for abstinence and recovery using different principles like relapse prevention. They need to be taught because we learned that addiction is a relapsing brain disease, much like other psychiatric disorders. So relapse is very likely. And so our clients need to be taught, our patients need to be taught, and they need to acquire skills to prevent relapse. So we provide relapse prevention, education, relapse prevention counseling, and therapies using behavioral and cognitive principles. Fourth guiding principle is positive support. So they live in an environment, okay? Dr. Siva mentioned how important genetics is, how crucial the role of genetics is in the development of a particular disorder. Now, we also have to consider the fact that environment also plays a significant role. When you ask the question which makes the car run, the engine or the gasoline, both are actually very important. In fact, there's now another factor, the driver, okay, or the psychological forces at play within the individual. But the point is, we have to nurture an environment that would facilitate healing and growth for the person. So to enhance a positive support from family members, we need to educate them about the illness. Many families still believe that SUD is a moral flaw, that it is a personality flaw, but it is, especially it is already a mental health condition, a mental health issue. And so they need to be properly educated as to why we consider it a relapsing disease. So they should be prepared when and provide the needed support when lapses happen. Okay. Now, and then another key factor is that short-term case management approaches during critical periods with high risk of relapse, okay, to promote treatment retention enhances successful outcome. Now, the treatment program has to be highly individualized to be effective. Now, monitoring, progress monitoring is very difficult unless we follow a case management approach. So we look into individual progress by individual to the desired outcomes through systematic monitoring. We also need to look into community resources for sustained treatment gains, or find the needed resources to whom we can refer clients who may, in the absence of such resources. Okay, so case management approach, especially during critical periods, is very important. Now, evidence points to the beneficial effect of psychosocial approaches in maintaining abstinence, adherence to medication, maintenance of a healthy lifestyle, better integration into the community, occupational rehabilitation, and an overall improvement in the individual's functioning. So there is evidence to that. However, okay, there are issues we have to consider. First, consumers of our patients, included their families, or in consumers of mental health care in general, find it difficult to know whether they are receiving high quality care. How would they know? That's why some of them just feel good. Some counselors who may not be trained to look into treatment goals and outcomes, but maybe focus perhaps on making the client or the patient feel good, okay, may be rewarded by gratitude from the patient who doesn't really know whether the care he is receiving is quality care. And providers, mental health providers, and many other providers of such interventions, we represent many different disciplines, okay? Different disciplines, which is good, no? But we also come from different types of facilities. Now, the delivery of care is oftentimes fragmented because we attend to this, we attend to that. One person does this, one provider does that. Sometimes intervention programs are not really integrated. So, and then these are also supported by varying levels of scientific evidence. Everyone claims that the intervention approach or technique he is using is highly effective. But what about our performance matrix? Do we have standards or uniform measures of checking on the quality of care delivered? Okay, are our tools and methods standardized? So this is an issue today. There are so many claims about therapeutic effectiveness. Okay, many of them may be true, but we cannot really generalize because even for evidence-based approaches, okay, it may work in certain cultures, but not in other cultures. It may work with providers who are trained to do this. But what about other providers? We don't even have a common use of terminologies. For instance, in CBT, cognitive behavior therapy, we use the term record, the record observation, okay, recording. Now in intrapersonal psychotherapy, we use mood ratings. More or less, if you would look into this, they're more or less the same, but each approach is using a different terminology, so that it is very difficult to standardize a really effective program for psychosocial intervention. Okay, now, so with these issues, what's the way forward? Okay, we want our interventions to be effective. We know, as mentioned earlier, that medication is not a standalone treatment. So we provide psychosocial support. Now, but evidence is still weak at this point. Therapeutic evidence is still rather weak. So we need to strengthen the evidence base of interventions. So we now call on our scholars, researchers to look into the evidence for effectiveness in various approaches of interventions by identifying the key elements of interventions. Now, we also need to conduct independent systematic reviews, because who's doing the reviews but the very proponents and users themselves, and this can be biased. So we need to conduct independent systematic reviews and develop, very importantly, we need to develop quality measures. First, for interventions, the intervention activities, we need to develop those activities. For implementing these interventions, the how to go about this across different individuals, across different cultures, and then ensure quality measures also for improving outcomes of these interventions. This we need to do. This is the way to go forward. And now, to end my discussion, let me present the framework for developing standards for psychosocial interventions. This I got from the interventions, okay, for mental use disorders, okay, science for health science and policies, developed by a committee for developing evidence-based standards. Okay, now, okay, in working out, of course, the standards for psychosocial interventions, first, we need to engage our patients. We need to engage the public. We need to engage the community, all stakeholders and consumers of the services we provide. Okay, strengthen evidence base, look into studies that claim evidence for different approaches for different particular client groups. Okay, let's see if this would apply to all. Okay, identify the elements, the key elements of the intervention program, conduct independent systematic reviews to inform clinical guidelines. Maybe that's the reason why psychosocial interventions are not really used in clinical practice. Okay, the community at large would use these interventions, but was really monitoring. Now, for claims of effectiveness, what are the proofs? We don't even have systematic guidelines for measuring therapeutic effectiveness. So we need to develop quality measures, and then measures to implement interventions and improve outcomes. all this, we all need to work together. So with this, I end my presentation, but let me just go through how we are doing things at New Day Recovery Center. So we have a multidisciplinary team composed of the psychiatrist, is a neuropsychiatrist actually, a nurse for every patient. We're talking here about a particular patient who works on the particular case, the psychologist, the case manager, who's normally the social worker, the psychometrician who looks into assessment. And then, so we have an example here of life skills, okay, how we're doing it during COVID-19 pandemic. Okay, so they're under individual maps. They have their own masks, even if they live inside the facility. So we can only handle so much. They have to be handled as groups. So we don't have a population of more than 20 as required by our Ministry of Health here. Okay, so that's our neuropsychiatrist giving psychoeducation on life skills lectures. Okay, our psychologist also, okay, doing her own life skills lectures. Then we have group therapy during COVID-19 pandemic. Okay, now before, this is an example of multiple family therapy. This was prior to the pandemic. If you notice, this is a group of mothers. We separated the fathers. Okay, so this was before the lockdown. Okay, we separated the mothers from the fathers, the spouses, female spouses, because of their distinct issues. Okay, and now this is how we're doing multiple family therapy. So it's a really virtual, now online. Okay, so thank you very much. So like the other speakers, I now turn this to our host for the needed questions.
Thank you very much, Dr. Miriam Q, for a wonderful presentation. And we can see that psychosocial intervention is very important in integrating services to substance use disorder as well as mental health disorder, and also, of course, the comorbidity between the SUD and also mental health disorders. So we are also pleased to see the activities that you've done in New Day Recovery Center in the Philippines. So there are some changes before COVID-19 pandemic and after COVID-19 pandemic. All right, we are going to continue with the discussion session. I think we have approximately 15 minutes for discussions. And I would like to invite all speakers for this session. We have received several questions in the Q&A column. However, we cannot accommodate all the questions, and we are going to discuss some of the questions. I have an interesting question here for Dr. Siva Kumar. There's a question about co-occurring disorder. So based on the definition that co-occurring disorder is when substance use disorder and also mental health disorder happen at the same time. But why is there hypothesis that one condition can cause the other? So this is a very interesting question, I think. And Dr. Siva, what do you think about this?
Sure. I think that sometimes people actually misunderstand what it really means, but don't mistake or don't confuse the co-occurring compared to induced disorder. Let me give you examples so that you understand clearer. If I'm a meth user, and because of my methamphetamine use, as soon as I use my methamphetamine, I start hearing voices and I start seeing things. So I have psychotic symptoms. So that mental health problem is called a methamphetamine-induced psychotic disorder because there's a direct connection. Whereas in the occurring disorder where when we talk about the direct causal hypothesis, it's a bit different. There is no direct cause. Like for example, the example I gave you, like I give you another example. Let's say I have anxiety disorder. So I'm feeling very anxious and I can't do anything because I'm anxious. So to calm my anxiety, I drink. See, the anxiety is not causing the drug, the alcohol problem, but I choose to drink because by drinking, I calm myself. So that is a self-treatment kind of thing, you know. So that is what it means by direct causal hypothesis. So make that difference. It's a huge difference.
All right, thank you, Dr. Siva, for the answer. And there's also another question about genetic factor of substance use disorder. Is this genetic vulnerability something that is already happened with someone from the time this person is born? Or is there any factor of exposure during the lifespan?
Yeah, thanks for that question. I think that's an interesting question. I cannot blame everything on genetics, okay? Because just like what Miriam was saying and what Dr. Dia was saying, it's multifactorial. It's multifactorial. But from research, we know that at least there is a 40% shared genetic predisposition for mental health problems and substance use problem. There's at least 40%. Yes, you're right. In those 40%, it is actually there before you are born. I give you a small example. A lot of people smoke cannabis, but not everyone who smokes cannabis becomes psychotic. Only a small percentage of them get psychotic. Why? Because when you actually do a test in those people who become psychotic after cannabis, you will find that they have a lack of a certain enzyme in the body that cannot break down the chemicals, especially chemicals like serotonin, which go high. And why they cannot break down is because they lack a genetic link. So there is a change in genetic and which they are born with. So we keep telling people that, of course you can do a genetic test, but it's too expensive. But of course we tell people, if you have already taken cannabis and you have got psychosis, it is in your genes most probably, so don't do it again because you will get psychotic. You get a psychotic disorder. So yes, it is there even before you are born. But remember, it's not the causal for everything. It is one part of the multifactorial cause.
Thank you, Dr. Siva Kumar. So yeah, the point is that this is a multifactorial disease. So we cannot just rely on one factor only. I think I'm going to bring up questions and discussions about the changes in the situation in this pandemic. I think the situation has made us to adapt the situation specifically in delivering the services. And there's one question for Dr. Miriam about the delivery of psychosocial intervention. Well, we've seen from your pictures that there are differences for the family group therapy, but are there any differences or let's say adaptations to the delivery of services during this pandemic? Dr. Miriam Q.
I would say that it is in the method of delivery. For instance, if we did, what we've seen actually in those pictures are residential patients, inpatients. Now, so that we are very particular about admission protocols because, we have a responsibility to those patients. So we want to ensure that after admission, we only admit those who have undergone COVID testing and that they still go through a quarantine period before they get to mix with the other patients. Now, I would say this has affected community-based treatment because we need to limit the number of participants since they go home to their respective families. So I would know some communities still there to meet a few clients from time to time with face shields and masks and all that. But so I would say it is in the method of delivery, like counseling and psychotherapy now, especially for our individual clients, are done through telecounseling, teletherapy. So I get to meet clients, okay, several miles away through Zoom, through other apps, just so we get to talk, we get to discuss issues because I'm also quarantined in another province and they are in another province. So far, I would say that based on client feedback, things have been quite the same, but that's client feedback, which is based on subjective experience. So many things have really changed because of the pandemic. And at the very start of the lockdown, many of our residents were very agitated. And I would like to look at that agitation in the context of frustration, aggression, frustration theory. And so, because they felt helpless, they were away from their families, they didn't know what was happening, and here they were consumed with guilt for what they have done for the rest in their lives. So somehow, topics for psychoeducation also changed to address those issues. Counseling interventions also changed because of those issues. But basically, I would say the activities more or less were still the same, just the distinct method of delivery in those services.
Yes,
so we still do assessment, but
okay.
assessment is also done in-house.
All right. So there is a change in the method of delivery, but somehow the clients, the subjects, they feel that the treatment is still, work the same for them. And
Let me add a bit, Dr. V. Even for single family therapy, before they go out back to their families, we do this through Zoom. So all the parents, family members, come in online and with the patient, and of course the therapist and the case manager.
Okay, that's very interesting. Yeah, so there's a change in this rehabilitation inpatient setting. I would like to go to Dr. Dia to add a little bit more about this topic, about the situation in Indonesia. What do you think, Dr. Dia, the change in the delivery of service for mental health and also substance use disorder? I think you're still muted, Dr. Dia.
Yeah. I think the situation in Indonesia is similar with the other country like Philippines. There are many challenges and also many obstacles to delivery the mental health and also for the substance use disorders clients. But we try to do that with the how to deliver it with the daring or the telemedicine is I think this is the best way for keep in touch with the clients. And we also in Indonesia, especially for the chronic clients and has a maintenance treatment, they cannot just 2 weeks or 1 month, but it could be for 2 months they can get medicine. So the frequent, it is less frequent than before to going to the hospital. And also we doing collaboration with the other provider like the Halodoc and others to deliver the medicine for them, so they don't have to go to the hospital to get the medicine, but the report or the status should be keep in what is it? Yeah, in a better condition, because whatever we did for the clients, it should be in the noted in the status. So this is the important things to do, to write down everything that we did to the clients, that we deliver intervention in the client status, and keep in the digital or the online report. I think this is my opinion.
Thank you, Dr. Dia. So now we have to adapt with telemedicine, and like what Dr. Dia has pointed out, that documentation is very important, like writing down every progress and treatment in the medical record. I think one last question, the same question for Dr. Siva Kumar. I would like to know how about the situation in Malaysia in terms of delivering SUD and mental health services during this pandemic time. This will be our last question, I think.
Okay, thanks, Suri. I think a lot of things have changed in Malaysia in terms of the delivery of treatment for mental health and addiction. I've got to say that it's most probably not as good as what's going on in Indonesia and Philippines. We are still very much in hospital based. We have basically not embarked on a whole scale in terms of teleconferencing or consultation. So still a lot is at the hospitals. But of course, we've got centers, 24-hour centers where we can actually receive people and treat. I have, I mean, personally, no objections against it, Dr. Miriam, but I have my reservations about this teleconferencing. I'm not a real big fan of it when it comes to actually giving psychosocial programs, because yes, the presentation is one, seeing your face is one, but I think there's a lot of other body language, a lot of other issues that come into face-to-face thing, which makes the psychosocial thing a success. So I'm not too sure how successful this way is, although we are thinking of running that. It's always interesting. NA groups run by teleconferencing, but how successful? Because they are more than just passing that message elements. There's more than that, So yeah.
Yes, Dr. Siva, I understand where you're coming from, but there's no other way we can do it under these limiting circumstances.
Yep.
So better do it than no intervention at all. Now, but we also limit teleconferencing to individual clients and to individual families. Now, so those inside are privileged. Those living inside are privileged because they can actually communicate with one another.
Yes. Thank you. That's a very interesting issue, I think, that there's a different sense when we provide psychosocial interventions, such as like consultation or counseling through conference or media. However, I think that's the best we can do for now, rather than not doing anything. But yeah, I think we need to adapt and learn more coping mechanisms for us in delivering this services for mental health as well as substance use disorder patients. I think we're running out of time, and I would like to thank all speakers for giving a very wonderful talk and a very fruitful discussions. And thank you so much once again. Thank you, Dr. Dia. Thank you, Dr. Miriam Chiu, Dr. Siva Kumar, Dr. Danardi, who is still with us until now. And for the record, Dr. Danardi has also answered questions which are asked by participants in the Q&A column. And we are very grateful for all participants who are still with us. 500 participants still stay here up until now. And we are going to close this session. I'm going to return the mic to our host, Veronica, who is going to lead with the photo session and also the closing. Thank you once again. I would like to give a big hand round of applause for our speakers. Hopefully it connects to you. Thank you so much. And Veronica, I return the mic to you back.
Thank you, Dr. Zulfia Sharif, psychiatrist, and also the greatest speakers here. And we remind you the speakers can also answer the question in the Q&A column in our provider. And thanks to all of you and Dr. Zulfia Sharif for guiding us in this our virtual seminar this afternoon to evening. Yeah. This seminar is very interesting and can open our horizons according to today's topic, substance use disorder, mental health, and COVID-19 pandemic changes and challenges. And we also express our gratitude and highest appreciation to the value speakers, Danardi Sosro Sumiharjo, medical doctor, consultant psychiatrist, Diah Setia Utami, medical doctor, psychiatrist, doctorate, Mars, Ziva Kumar Turai Raja Singam, MBBS, MedSig, doctor, consultant psychiatrist, associate professor from Monash University, Malaysia, Miriam PQ, PhD RC, RPM, RGCIC AP3 from Philippines, and also our moderators who has a beautiful dress in this evening, Zulfia Sharif, medical doctor, psychiatrist. For this precious moment, the speakers are welcome to stick to their respective video lines because we will take photos or screenshot together to capture this moment. Please stay tuned and activate the video, dear speakers. Okay, give me the most beautiful smile for all of you. 1, 2, 3. Okay, once again, give the best style for all of you. 1, 2, 3. Good, thank you for dear speakers. We were informed to the doctors and that we have shared the post-test from and downloadable material in the chat column. Ask the participants to send the form, Neuro medical doctor, doctorate, consultant psychiatrist, professor. During his lifetime, 3rd October in 1924 to 27 September 2008, it means 84 his age, he devoted himself completely to advancing the science of Indonesian psychiatry. We pray for all of us here, the psychiatrists and the scientific development of psychiatry in Indonesia can continue to progress and develop and uphold high spirits as exemplified by Professor Dr. Kusumanto Setionogoro, consultant psychiatrist. Let us all pray and be quiet for a moment, especially to remember him and the mental health of the Indonesian people during this pandemic. Thank you for all of you. Doctor, don't move ahead. Let's watch offerings video from PT Mercy Pharma. Ladies and gentlemen, we don't feel like we are at the end of the event. Let us deliver the sponsor key message. If the doctor finds an indication of the patient's doctor, please don't hesitate to choose Atarax. 0.5 milligrams and 1 milligrams help patients stay calm, best solution for panic attack. Merlopam, 0.5 milligrams and 2 milligrams tablet, safe and effective for short treatment anxiety. Duloxta, duloxetine 60 milligrams, the excellent choice for depression, anxiety, and pain. Valimax tablet, an injection, and Clofritis 10 milligrams, the first choice anti-anxiety. Lexapam, safe and tolerated for treatment anxiety. And other products of Mercy Pharma such as Bamgetol, as mood stabilizer, effective as monotherapy for partial and generalized secondary epilepsy, Kutoin capsule and injection, and Cibital to manage of convulsive status epilepticus, and also Dolgesic, potent analgesics for acute and chronic pain. Thank you, Doctor and colleagues. We will inform you for the certificate in this virtual seminar. It will be sent via email to each registered doctor and all of you, those who have attended the event and have successfully taken post-test. Dear doctor, we thank you for the participation and support of the committee and all parties who have helped make this event a success. Until we meet at the next virtual seminar, good evening. Greetings, healthy mental. Keep your health protocol in check. Greetings, Mercy Pharma, and see you.
Thank you.
Thank you, dear
Siva.
fellow speakers.
Thank you, Vero.
Thank you.
Thank you, Dr. Vivi.
Thank you, Dr. Dia, Dr. Danardi. Dr. Miriam,
Sama-sama,
thank you.
terima kasih.
Miriam, see you.
Thank you very much.
Thank you.
Bye.
Riza.
Bye, Ate. Bye,
Bless
Dr.
you.
Bye.
Terima
See you
kasih.
next event.
Ya,
Stay safe. Bye-bye.
terima kasih
Terima
semuanya.
kasih.
Terima kasih, Mbak Vero.
Bye, thank you,
Terima kasih,
Dr.
Pak
Dia.
Vero.
Thank you,
Terima kasih,
Dr.
PT
Vina.
Mercy.
Thank you,
Terima kasih,
Mercy.
PT Mercy.
Semuanya. Ini deh, ya.
Doctor,
Thank you,
Nah,
Professor.
sukses ya
much.
acaranya.
Thank you,
Terima
Dr.
kasih.
Danardi.
Ya.
See you, Dr. Miriam, too.
Kenapa?
Thank you, Veronica.
Oh, Pak Kasbandi, terima kasih Pak Kasbandi untuk dukungannya.
Terima kasih,
Dokter
Pak
Eva,
Kasbandi.
terima kasih Dokter Eva.
Thank you, Dr. Eva.
Thank you.
But you know, I wanted to say this earlier, but I'm so impressed that Indonesia has the statistics for mental health cases
Thank you.
during this pandemic. Yeah, and that Dr. Dia, that you are prepared with your response. You have guidelines. Our government is ill-equipped, unfortunately.
Thank you, Dr. Miriam.
You can adopt from our association.
Yes, that's why I'm glad. There were those who attended from the Philippines, so they will learn
Yes, thank you.
what to adopt. Thank you very much.
Thank you. We have
Okay,
several
you're
Philippines participants. Thank you.
Yes, thank you very much. I'm sure they
Yes.
learned a lot, especially
Okay,
from
see you.
Dr. Siva and Dr. Dia. Okay, thank you so much.
Thank you so much. See you again, Dr. Miriam.
Dr.
Bye.
Thank you, Dr. Vivi.
Thank you.
Dr. Risa, thank you.
Selamat datang di Mercy Pharma, Pelanci Kembar Sukabumi. Pabrik yang dibangun di atas lahan 14 hektar, terdiri dari 8 bangunan gedung produksi, dengan fasilitas ruang kantor dan R&D. Serta dilengkapi dengan laboratorium kimia dan mikrobiologi yang modern, bertujuan untuk memenuhi kapasitas besar produksi obat-obatan. untuk pengembangan produk, peningkatan kualitas, dan pemastian mutu produk yang dijalankan oleh SDM profesional dan berintegritas tinggi yang menempatkan mutu produk sebagai pedoman utama dalam karyanya. Sejak berdiri pada tahun 1997, dimulainya pembangunan hingga 1999 mulai berproduksi, didukung dengan fasilitas produksi dengan teknologi terkini yang memenuhi standar cara pembuatan obat yang baik. Dalam wujud visinya menjadikan Mercy sebagai industri farmasi unggulan di dalam negeri maupun di luar negeri yang berstandar internasional. Tujuan kami adalah untuk membuat produk-produk berkualitas tinggi yang berkapasitas besar, efisien, dengan biaya kompetitif di pasar lokal dan ekspor. Kami bangga memiliki peralatan yang baru dan modern untuk melengkapi fasilitas canggih kami. Semua peralatan diuji dan divalidasi sebelum setiap produk diproduksi. Prasarana untuk kelancaran produksi sehari-hari mencakup compressed air untuk menggerakkan mesin produksi, purified water system, sistem pengolahan air murni untuk bahan baku obat, dari penjulingan hingga distribusi ke semua gedung. Boiler room, proses pembuatan uap panas untuk proses produksi dan proses pengolahan water for injection. Gedung unit-unit produksi sebagai gedung pengolahan obat-obatan dengan bahan baku kimia. Memproduksi beberapa jenis produk unggulan antara lain tablet salut, kaplet, kapsul, serbuk oral, injeksi, infus, maupun cairan oral dan krim obat luar. Untuk dapat mempertahankan kualitas hingga lini akhir, proses produksi Mercy menyimpan produknya dalam gudang dengan kapasitas lebih dari 3.500 palet, terbagi atas beberapa kondisi suhu dan kelembaban tata ruang. Guna menjalankan misi Mercy untuk menyediakan dan memasarkan obat yang bermutu, tersebar merata, tersedia cukup, dan terjangkau masyarakat seluas-luasnya. Untuk meningkatkan derajat kesehatan masyarakat Indonesia dan internasional, dengan kantor perwakilan Mercy siap melayani pelanggan di seluruh Indonesia. Pada masa yang akan datang, diharapkan Mercy dapat memelihara dan meningkatkan eksistensi perusahaan untuk membangun Indonesia dalam dunia kesehatan. Karena kesehatan Anda adalah prioritas kami. Kami yakin dengan kualitas obat yang baik akan meningkatkan kualitas hidup